Good morning, and let me formally welcome you to the 2020 ABTA National Conference. As you heard, this year we're presenting it fully online. As you know, today is the 19th anniversary of the horrific terrorist attacks, taking nearly 3,000 lives. Let's pause for a moment to remember and honor those that lost their lives, their families, and the first responders. Thank you. I'm Ralph DeVito, President and CEO of the American Brain Tumor Association. We are thrilled that over 1,000 people have registered for this year's national conference. Welcome. You can join us for the entire 2 days or for any part of it that your schedule allows. Many of you are joining us for the first time. The ABTA National Conference is the largest educational meeting designed specifically for patients, survivors, and caregivers who've been impacted by a brain tumor diagnosis. We hold this conference annually, and we convene the nation's leading brain tumor experts to provide the latest updates in brain tumor treatment, care, and research. We decided to present this year's conference virtually to protect the health of our community during the COVID-19 pandemic. We have people from every part of the US and from around the world joining us. This great level of interest reaffirms the need to bring the latest advancements in brain tumor treatment and care to those impacted by a brain tumor diagnosis. Thank you for joining us. You may be joining us from your phone, from a waiting room. You might be joining friends, maybe a brain tumor support group have come together to join together, or you might be enjoying this conference from the comfort of your own living room. Regardless, we come together as a community to learn, to be inspired, and to resolve to take action. Although we're physically apart, we're united in our commitment to improve, extend, and ultimately have no life lost from a brain tumor diagnosis. Again, thank you for joining us. I am confident that the content developed by our amazing co-chairs, Mark and Jean, who you'll hear from in a moment, and from the staff will inspire you and motivate you to act. Now it's my pleasure to invite Jim Riley, Chair of the ABTA Board of Directors, to offer his welcoming comments. Jim?
Good morning, Ralph. Thank you. As a two-time caregiver to my mother and mother-in-law, both diagnosed with a brain tumor, I look forward to this conference every year, as the information I learn and the people I meet fills me with hope for our future. This is the kind of hope that birthed the American Brain Tumor Association. The ABTA emerged 47 years ago by Susan Kramer and Linda Goldstein, both mothers whose daughters were diagnosed with a brain tumor. Back then, there were limited educational or support resources available, and brain tumor research funding was abysmal. Susan and Linda were determined to build an organization to serve the patient through information, support services, and research. I share this with you simply because I want you to know that this conference is uniquely designed for you. By bringing together our nation's medical leaders from all over the world, we hope to provide you with the most accurate and relevant information and support services to inform you and empower you. We hope you find the information presented at the conference helpful and meaningful to your brain tumor journey.
Thank you so much, Jim. I would like to now take a few minutes to acknowledge those who have helped put together this wonderful virtual conference. Thank you to all of our speakers, whom you will hear from throughout the weekend, for sharing their thoughtful insight and expertise tailored to patient and caregiver needs. Thank you to all of our sponsors and funders for their support of this conference. I want to especially thank our presenting sponsor, the Sontag Foundation, for eliminating barriers and enabling patients to access this conference free of charge. You will hear from the Sontag Foundation and from the Brain Tumor Network later this morning. Thank you to all of our researchers who you will hear from during our breaks throughout the weekend. And last, but certainly not least, I would like to thank our conference planning co-chairs, Dr. Mark Gilbert and Jean Arsbaker, who have put together an incredible programming, bringing together national experts from top medical institutions to share with you today. Dr. Mark Gilbert is the Chief and Senior Investigator of the Neuro-Oncology Branch at the Center for Cancer Research at the National Cancer Institute, National Institutes of Health. Dr. Gilbert's research interests center on developing new treatment strategies for patients with malignant primary brain tumors. Jean Arsbaker is an advanced practice nurse at the University of Illinois at Chicago. Jean has facilitated one of the largest brain tumor support groups in the southwest suburbs of Chicago for the last 11 years. Please welcome Mark and Jean to say a few words.
Thanks, Emily. I'd like to take this opportunity to personally, but of course virtually, welcome you to the 2020 ABTA National Conference. I'm honored to be the co-chair of this event with Jean Arsbaker. I think we have an amazing program for you that covers a wide spectrum of topics that have been very carefully selected to provide important information that will help you navigate these serious illnesses. More importantly, we think that this meeting will provide you with hope as you get an idea of all the work that is going on to improve outcomes in patients with brain and spinal cord tumors. I'm very excited about the next 2 days. So as Emily mentioned, I recommend that you get a comfortable seat and join us for this outstanding program. Thank you.
Good morning. Greetings from a wet and chilly Chicago. I would like to personally but virtually welcome you to the 2020 ABTA National Conference. It has been an honor and a privilege to work with Dr. Gilbert and the ABTA team to organize this conference. We hope that the topics and speakers we have selected will motivate and inspire you as you continue on your journey. I would like to thank you, the survivors and caregivers. You impress me every day with your strength and resilience. Welcome.
Thank you so much, Mark and Jean. We would not have been able to bring you this quality educational programming without our co-chairs' guidance and support. You will be hearing more from our co-chairs throughout this weekend. I would now like to welcome Ralph DeVito, who will introduce our next session.
Thank you, Emily. Good morning again, and I am happy to introduce our first session. It's all about the American Brain Tumor Association. This was a well-received session last year, and delighted to have it back again this year. The ABTA continues to be a proud advocate, and we are steadfast in our mission to be a strong ally and resource for the entire brain tumor community. This presentation will discuss the many ways we are here to serve you and how you can get involved. Please help me welcome our presenters for this session, ABTA's Chief Mission Officer, Dr. Nicole Wilmarth, and Alicia Morris, ABTA's Director of National Volunteers.
Great. Thank you, Ralph. I'm excited to be here today with all of you to talk about ABTA's mission. Next slide. But first, I'd like to take you back 47 years ago, before ABTA was founded. Back then, there was really no coordinated funding of brain tumor research. There wasn't a medical specialty that was dedicated to brain tumor treatment. We now have the field of neuro-oncology. There wasn't any national tracking of the incidence and the prevalence of brain tumor diagnoses, both malignant and non-malignant. And now we have the Central Brain Tumor Registry of the United States. And there also wasn't any education or awareness or funding programs that were really focused on brain tumors. And of course, you're all here today at our national conference. Next. And ABTA is really proud to have played a pivotal role in helping to close those gaps. However, we know there's so much more to do, which brings me to our mission. The mission of the ABTA is to advance the understanding and treatment of brain tumors with the goals of improving, extending, and ultimately saving the lives of those impacted by a brain tumor diagnosis. And we work toward our mission by taking a multifaceted approach through brain tumor patient and caregiver support, through public education and awareness, as well as strategic partnerships with other organizations and institutions, and as well as funding of research. And so now I'd like to go into some of our mission and action. And I'll start with research, since research is our legacy. ABTA is very proud of our research program. We've been funding research since ABTA started, and we fund it every year. The ABTA funds research across all tumor types, primary as well as metastatic, and all ages, pediatric to adult. We fund research, and we've invested in brain tumor research at over $32 million to date. We have supported over 700 research projects through the US and globally, and we have supported over 630 different researchers. Next. But we also know it's important to continue to support early career investigators who are entering the brain tumor research field, as well as supporting those that are currently in the field and to help retain them. And so we started the ABTA Alumni Research Network, or what we call the AARN. This started back in 2012, and it's a network of brain tumor researchers that have been funded by an ABTA grant. And we bring them together every year for a 2.5-day meeting where they get to network and they talk about new ideas, research concepts, they talk about brain tumor science, but they also talk about career development topics such as grant writing and how to manage a lab. And what we've seen is every year that we bring these ARN members together, there's a trust that forms, there's collaboration. And we have recorded 43 past and current collaborations amongst these ARN members. And these collaborations have led to over 30 publications and also joint funding. And so we're seeing research advances coming out of our AARN network. Next slide. I also wanted to talk about a couple of other research initiatives that we support. One is the Brain Tumor Funders Collaborative. And this is a partnership among private, philanthropic, as well as other advocacy organizations where we pool our funding to invest in larger projects that are bigger than we could fund individually. And the BTFC funders are currently collaborating on 2 different topics. One is on long-term survivors of GBM, and another is that we recently awarded $3 million to 4 different research teams that are studying immunotherapy in primary brain tumors. So we're really excited to see what comes out of those projects. In addition, the ABTA has provided funding to start a low-grade glioma patient registry. And the purpose of this registry is to compile and evaluate data that details response to treatment as well as clinical outcomes from patients. Next slide. So those are the highlights I wanted to show you regarding our research program. And now I'd like to switch gears and talk about patient services because we offer a robust portfolio of services and programs that may be of interest to you. Next slide. I'd like to start first with our website. Our website houses a ton of information on tumor types, diagnosis, symptoms, treatments, all vetted by experts. We also have a caregiver resource center as well as a pediatric caregiver resource center. And we have a number of listings. One includes brain tumor treatment centers. So if you're looking for a brain tumor treatment center near you, you can check our listing. And also we have a listing on brain tumor support groups so that you can find a support group that's located near you. Next slide. I also wanted to mention our educational materials. ABTA has 18 printed educational brochures that are available to patients and families for free. If you would like one of these brochures, all you need to do is go and fill out a form on our website and check off the ones that you would like, and we'll send them to you for free. They include topics such as a range of tumor types, as well as treatment types, such as chemotherapy, radiation therapy. We even have one on clinical trials, a caregiver handbook, and one for the newly diagnosed. So this is a great resource. You can also download them off of our website as electronic versions in PDF form. Next slide. We also have our care line, which is an information center. We take calls or emails, and these are answered by our trained and caring staff. And they provide information, assistance, and resources to help you. So we're here to help you. You can call our care line at 1-800-886-2282. Next slide. I also wanted to mention our online support community called Connections, and this is housed on Inspire. And this is a dedicated online community for brain tumor patients and caregivers. And we have over 28,000 members on Connections. So this is a very active support community. It's available 24/7, and you can go on and you can search the forums by topic of interest, whether it be a certain treatment that you're looking for information on or tumor type. Next slide. And if you haven't checked into one of our live webinars, I encourage you to do so. We hold these almost every month, and they are presentations that are given by experts in the field, and they're live, so you can listen to the presentation and then you can ask your questions afterwards. We also record them, so if you can't attend live, we will house the recording on our ABTA YouTube channel, and so you can go back and find any topic of interest that you want on our YouTube channel. Next slide. I also wanted to mention our regional and patient and family meetings. And typically we hold these around the country in partnership with institutions. But of course, this year with COVID, we have converted them to virtual events. But these are typically free half-day educational meetings that are led by medical experts. And we talk about a wide variety of topics that include latest research updates, treatment overviews, or side effect management. And we have an upcoming one in Los Angeles, California, in partnership with USC. And this will also be a virtual event on November 14th, 2020. So I encourage you to register for that event if you're interested. Next slide. And of course, our national conference, which you are all a part of. Normally this would be an in-person meeting, and we wish we could see you all in person. But we are very happy that we're able to deliver the content virtually this year. It's a 2-day event, typically. Our educational conference is the largest in the country, where we're bringing together the whole brain tumor community, from patients to caregivers, healthcare providers, researchers, to learn about brain tumors. We have topics for newly diagnosed, survivors, and caregivers. And this year, because we're virtual, we also have free registration. So we're very glad you could join us. Next slide. And last but not least, we have our peer-to-peer mentoring service. And this is a service, if you're looking for more one-on-one support, this may be perfect for you, where we connect newly diagnosed brain tumor patients and caregivers with mentors with a similar diagnosis. So you can talk to somebody who's walked in your shoes. And they provide compassion and support and guidance to help ease the brain tumor journey. This has been a very popular service, especially during the COVID pandemic. We have 740 mentees matched to date, and 215 patient and caregiver mentors who are trained and ready to help. So if you're interested in this service, please reach out to us, and we're happy to connect you. And I think that's everything I was going to cover today. So I'm happy to turn it over to Alicia Morris, who's our volunteer director, to talk more about getting involved. Alicia.
Thank you, Nicole, and good morning, everyone. We are so excited to have you with us today, and I wanted to take a moment to share some of the ways you can volunteer with us. Next slide, please. Fundraising is one of the most creative and flexible ways to volunteer. Many of our volunteers really enjoy participating in fundraising events because it combines doing what they love while supporting a good cause. Some fundraising opportunities include joining Team ABTA, our endurance running and cycling program, or Fundraise Your Way, which allows you to create a tribute page via the ABTA website, host your own event such as a golf tournament, a bingo night, or a virtual concert, or celebrate a milestone where you will would receive donations in lieu of gifts. Next slide, please. Another really awesome way to volunteer is by joining one of our 5Ks. This year, we've moved to a virtual platform that will allow anyone in the country and the world to participate. You can create a team with family and friends and complete your 5K your way. In anticipation of being together again in person next year, we have a host of ways you can volunteer at an event. You can serve as a committee member, bring a group of volunteers to help out at our booths or on the course, and much, much more. Next slide, please. Other amazing opportunities include serving as a corporate ambassador at your company, joining our research team as a patient advocate reviewer of our yearly grants, training to become a peer-to-peer mentor, represent us at a regional meeting or a community event, or fill one of our skill-based volunteer needs. We always need support with short-term projects. Next slide, please. With the guidance of our National Volunteer Advisory Council, we aim to provide you the best volunteer experience possible. Our council is a group of hand-selected volunteers who have years of expertise in one or more of our volunteer areas. They are here to support you, so please feel free to connect with them and learn more. And your first opportunity to do that will be this afternoon at 4 p.m. Central Time. Don't forget to join us for the Volunteer Social Hour. You will hear from the volunteers themselves on the best ways to get involved. It will be an interactive session because we really want to learn more about you. We look forward to seeing you a little bit later, and please enjoy the rest of the conference.
Thank you so much, Nicole and Alicia. For those of you who need a break, please take this opportunity to stand up and stretch your legs. We invite the rest of you to stay on to hear from our sponsor, Northwestern Medicine. We will be back at 10:55 a.m. Central Time for the next session.
Hello, my name is Roger Stoop. I'm an oncologist specialized in brain and spine tumors, leading the Northwestern Medicine Brain Tumor team. With locations in Chicago, the western and the northern suburbs, Northwestern Medicine's elite, patient-centered brain tumor program offers the highest quality, compassionate and innovative treatment for patients in Chicagoland, the Midwest and beyond. The caliber of our program is reflected by the top 5 ranking of Northwestern Memorial Hospital for neurosciences and neurosurgery by US News and World Report, and the highest possible ranking, exceptional, received by the Robert H. Lurie Comprehensive Cancer Center from the National Cancer Institute. Today, members of Northwestern Brain Tumor team will talk with you about Courtney, a 38-year-old mother.
Courtney's husband brought her to the emergency room after she had a seizure. An MRI revealed a lemon-sized mass in her right brain, and I saw her in the clinic the day after she was discharged from the emergency department. Prior to her appointment, I had reviewed the imaging with our expert neuroradiologists.
Neuroradiology is a subspecialty that focuses on the diagnosis and characterization of abnormalities of the brain and spine using neuroimaging techniques. Dr. Lucas shared Courtney's case with me, and we reviewed her MRI together. Based on her MRI, I suspected a low-grade glioma.
When I met Courtney, I explained the suspected diagnosis and the next steps to be considered. I suggested that she meet with one of our neurosurgeons that day to discuss surgical options. Because our multidisciplinary team is co-located, we just had to go across the hall for Courtney to meet with Dr. Lesniak.
We felt that awake surgery would allow for maximum safe tumor resection, while ensuring the surgery would not impact Courtney's functional ability like speech and memory. Courtney did very well in the surgery and left the hospital after only 2 days. The resected tumor tissue was then analyzed in detail by our expert neuropathologist at the Lurie Cancer Center for state-of-the-art tissue and molecular diagnosis, which is important for guiding post-surgical treatment.
The Neuropathology Division at Northwestern Medicine is a world leader in brain tumor diagnosis, including the use of next-generation sequencing. These new technologies allow us to classify tumors more precisely and to understand their genetic makeup since tumors with certain genetic markers will respond better or worse to different treatments. Pathology is a critical tool in our arsenal against brain cancer.
Days later, with Courtney's full pathology and molecular results, the whole team reviewed her case in one of our 2 weekly brain tumor boards. These meetings are attended by Northwestern brain tumor experts in the fields of neurosurgery, neuro-oncology, radiation oncology, neuroradiology, and neuropathology. This team also includes nurses, nurse practitioners, social workers, and cancer genetics counselors. Various treatment options are considered and discussed before coming up with a personalized recommendation.
We discussed her case at the Multidisciplinary Tumor Board, and it was decided that she would benefit from radiation therapy. There are several radiation therapy techniques used for the treatment of brain tumors, including regular fractionated external radiation therapy with X-rays or protons, gamma knife radiosurgery, and fractionated stereotactic radiation therapy. The indications for these different treatments are mainly based on the type of brain tumor on pathology and genetic testing.
The consensus recommendation from Tumor Board was to treat Courtney with proton therapy. Proton therapy is an advanced form of radiotherapy that treats tumors with a precise dose of radiotherapy that conforms to the shape of the tumor with the goal of reducing the risk of side effects and damage to surrounding healthy tissues. This treatment is being studied for patients with Courtney's tumor type, so we proposed she enroll in this clinical trial. After a detailed discussion of the trial rationale, she elected to participate and is now receiving proton therapy at the Northwestern Medicine Proton Center, which is the only proton center in Illinois and one of only 29 facilities in the U.S.
Through Courtney's care, I served as the dedicated social worker to her and her family. So much of brain tumor care is dependent on the patient and their caregivers having resources, guidance, and support. In Courtney's case, she elected to join one of Northwestern Medicine's monthly support groups. At Northwestern, we understand how difficult and frightening a brain tumor diagnosis can be for the patient and their family. We are dedicated to being there medically, physically, and emotionally every step of the way.
Ultimately, Courtney has had an incredible response to treatment. She was rapidly diagnosed and treated and is now doing very well and living a high quality of life with her family. All of us at the Northwestern brain tumor community are committed to advancing the understanding, diagnosis, treatment, and prevention of brain and spine tumors. We achieve this through innovation and scientific discovery, while providing expert, state-of-the-art and cutting-edge treatment, compassionate care, and support to both patients and caregivers.
I would now like to welcome our next session. Our presenting sponsor, the Sontag Foundation, passionately supports people and organizations who make a significant and continuing impact in the lives of individuals and communities, primarily in the field of brain cancer research. The foundation provides resources and support to patients and their families through the Brain Tumor Network and other support initiatives. In this session, you will learn about patient navigation and its positive impact on the patient experience. We will first hear from Rick Sontag, founder of the Sontag Foundation and founder of the Brain Tumor Network. He is a 23-year caregiver to his wife, a brain tumor survivor. Following Rick, you will hear from our presenters for this session, Stephanie Gebhardt and Eden Mock from our partner, the Brain Tumor Network. Please welcome Stephanie and Eden.
Thank you. Play video, please.
I'm Rick Sontag. I'm president of the Brain Tumor Network. And Brain Tumor Network was established in 2014, but let me tell you how we got to Brain Tumor Network. So back in 1994, I was running a company, and my wife Susan was a homemaker, and we were the parents of 3 college-age children. Everything was going fairly well for us, and then one day in June 1994, our world changed. Susan had a stroke and was diagnosed with a terminal form of brain cancer. So suddenly I found myself sorting through the information, trying to learn the disease, trying to learn treatments that are available, trying to learn treatment centers, physicians. It was an overwhelming situation for me because I was running a company and trying to be a caregiver as well as trying to learn how I should proceed and cope with the disease. We were lucky enough to get Susan entered into a clinical trial. That clinical trial went over a course of almost a year. It started with a number of very severe treatments, and in a few months she started having the tumor shrink, and eventually the tumor disappeared, so that Susan became a survivor. In fact, she is a survivor today, albeit with a number of medical problems. So during that time, I said to myself, you know, this is such an overwhelming situation for people like me, that if I get a chance to do something about this disease one of these days, I'm going to do something about it. And that happened back in 2002 when our company was sold. We took part of the proceeds from that sale and we founded the Sontag Foundation. We decided to start by funding medical research related to brain cancer. It was a good way for us to get into the field and know more about it. We started giving grants to researchers, and as of today, we have given over 50 grants to cancer researchers doing brain cancer related research in almost every major cancer research center in North America. We decided that we also need to do something for patients. So the first thing we did was we started a support group right here on our home turf of Northeast Florida, where once a month we would meet and we'd discuss problems associated with the disease and living and coping with the disease, you know, including things like memory and falling and seizures and the like. It was so successful that we have continued that support group to this day, and we've helped over 200 families. As we heard the stories of the people in that group, and as we got more people approaching us with their own stories of being diagnosed with brain cancer, we realized we need to go back to the same idea that we had back when I got the bad news in 1994, which is, how do we do something more focused to help people cope with the diagnosis of brain cancer and find their way to better treatment? And that's when we founded the Brain Tumor Network back in 2014. We founded it as an independent, not-for-profit. When you contact BTN, what you wind up with is you're talking to a skilled nurse navigator who will help you through the process of making a decision, whether it's getting into a clinical trial. We will help you get to the trial, help you identify trials that are appropriate. Second opinion, helping you with that. Just a reconfirmation of the disease that you've got. And we'll also help you with things that are kind of the social needs, like insurance and financial issues. Brain Tumor Network has no affiliation with any one medical institution. Likewise, it has no sponsorship or special affiliation with any medical equipment manufacturer or drug company. It therefore gives you totally objective and unbiased advice, and we do it all for free.
Thank you to Rick, Susan, members of the Sontag Foundation, the ABTA, and to each of you who join us here today. My name is Eden Mock, and I'm a social work navigator with the Brain Tumor Network, and I'm joined today by my colleague, Stephanie Gephardt, who's a dedicated nurse navigator with our team. We're pleased to share with you more about patient navigation, the mission and services of the Brain Tumor Network, and our impact through the patient experience. We would like to begin today with a focus on patient navigation model, which is foundational to the services the Brain Tumor Network provides. Patient navigation is still considered a relatively new term in the healthcare industry. The term itself, patient navigation, can mean several different things to various health institutions. Measures of the effectiveness of patient navigation are often mired down into patient acuity tools, which are metrics for demonstrating program value and the rate of hospital readmissions. We would like to take a step away today from the numbers to show the positive impacts of the brain tumor navigation model through the metric that matters most, the patient experience. In 2010, the Oncology Nursing Society, the Association of Oncology Social Workers, and the National Association of Social Workers released a position statement on patient navigation in the Oncology Times. They defined it as individualized assistance offered to patients, families, and caregivers to help overcome healthcare system barriers and to facilitate timely access to quality health and psychosocial care from pre-diagnosis through all phases of the cancer experience. Next slide, please. What is patient navigation? Well, the first patient navigation program was developed in 1990 by Dr. Harold Freeman, and this was based in Harlem, New York. This initial program was a response to the findings of the American Cancer Society's national hearings on cancer in the poor. And the goal of this first program was to save the lives of those who had been impacted by breast cancer by eliminating barriers to timely access to care from the initial cancer suspicion throughout diagnosis. Some of those earlier barriers that were identified were access, financial and access barriers, such as health insurance, communication and information barriers, medical system barriers, fear, distress, and emotional barriers. And we know those barriers are still true today. Next slide, please. Since then, patient navigation has evolved into a nationally recognized healthcare system model. And the Brain Tumor Network's mission is to provide compassionate and personalized high-touch navigation to adult patients and caregivers in the United States who have been diagnosed with a primary brain tumor. Our goal is to never lose sight of those that we serve and remain available across the continuum of care by providing personalized and compassionate services which are focused on individual goals and needs. And truly our goal is to empower those individuals and families with a focus on survivorship, navigating them through the initial diagnosis, through end of life as well. And survivorship is truly at the heart of our organization. And we have a deep-rooted commitment to guiding and empowering those that we serve each and every step of the way. Next slide. When faced with a brain tumor diagnosis, patients and families oftentimes feel lost in the amount of information that's provided to them at the time of when a diagnosis and stress is high. Our team of navigators will meet patients on their individualized paths, equipping them with the information and support that they need to make informed treatment-related decisions regarding their care. Since Brain Tumor Network's inception, our team has provided high-touch navigation to over 1,100 patients and caregivers from every state across the United States. And our services include connecting patients to disease experts and facilitating consultations, assisting with locating treatment centers with a focus on centers of excellence, providing education on current FDA-approved treatments for brain tumors and their associated side effects, locating second and third opinions while considering barriers such as geography and the ability to travel. Next slide. We'll also locate clinical trials based on an individual's tumor pathology. We'll gather medical records and deliver those records to medical institutions on behalf of patients and caregivers. We'll assist with questions and topics to discuss with care providers. Also provide psychosocial support and ancillary services along the way. And with the Brain Tumor Network, medical advice is not provided. All of our services, finally, are provided at no cost to our patients and our caregivers. Next slide. At the Brain Tumor Network, we truly have a team approach, and our team is made up of nurses, nurse practitioners, clinical oncology social workers, and medical advisors. And by working together as a team, we ensure we support each patient to address their individualized needs by identifying their needs, their concerns, and their goals. Next slide. I would like to share with you now the personal story from a patient and caregiver who have been followed by our team since 2015. Chris M. was diagnosed with an anaplastic astrocytoma, and the following is his story from his spouse, Sharon, and she writes, "My husband, Chris, was diagnosed with an anaplastic astrocytoma in February of 2015. The diagnosis was, of course, devastating, and care for him began so swiftly. After his resection, healing from surgery, 6 weeks of radiation treatment and Temodar, we were then on a plan of standard of care for a year. His neurology doctor said that I should immediately look for a support team to come alongside me with this challenging diagnosis. I found the Brain Tumor Network, and it has certainly been a lifeline to me. I called, and on the other end of the phone was our navigator. She and the other support team members are tremendous listeners and encouragers. This diagnosis was so new and scary to me. I simply didn't know what to do, and I wanted to take care of my husband and understand his diagnosis entirely. Together with our navigator, we pulled through the ups and downs of my husband's treatment. Unfortunately, within 11 months, he was facing a recurrence. Because I already had a navigator as part of our team, Chris, I contacted her to help us locate a clinical trial to assist Chris, and she was amazing. She had sifted through hundreds and hundreds of clinical trials on our behalf to find those that were most appropriate at that time. I truly would have been so overwhelmed. As I say, this was a lifeline of hope. We found a clinical trial that my husband was eligible for called Tokagen, and since that time, BTN's staff of nurse navigators and social workers have continued to be a lifeline for me. As we reflect on Chris and Sharon's story, I would like to transition now to my colleague, Stephanie, who will describe in further details our services in relation to the patient and caregiver experience with the Brain Tumor Network. Thank you.
Thank you, Eden. My name is Stephanie Gebhardt, and I'm one of the nurse navigators at Brain Tumor Network. As we've heard, clinical trials are often important treatment options that brain tumor patients can discuss with their doctors. Unfortunately, locating clinical trials is not always an easy process. Patients can sometimes become overwhelmed in pursuing trials due to a difficulty accessing trial information, a difficulty understanding the complexity of requirements, a fear of pursuing options apart from their current healthcare team, and perhaps location or financial challenges. Next slide. At Brain Tumor Network, we can provide personalized clinical trial searches if desired. With the patient's consent, we can utilize the necessary health information in order to locate the most specific trial options for their particular tumor type. Our proprietary software system and experienced staff can help locate and vet applicable trials. Brain Tumor Network continues to develop relationships with brain tumor centers throughout the nation. We often assist the patient and family in connecting with the treatment center for expert review and trial screening. Next slide. In order to develop a treatment plan, many patients wish to seek several expert opinions, but often don't know where to go or how to find such experts. Securing second or maybe even third opinions often provides additional insight and allows patients to be well equipped in choosing a treatment decision that best aligns with their personal goals. Since January of 2016, Brain Tumor Network has connected patients with over 420 specialists, including neuro-oncologists, radiation oncologists, neurosurgeons, neuropsychologists, and neuropathologists. Next slide. Empowering patients through education and information is the main goal at Brain Tumor Network. We have built partnerships with many organizations, including the American Brain Tumor Association, NCI Connect Rare Brain and Spine Tumor Network, the International Brain Tumor Association, and the National Brain Tumor Society. Since 2016, we have provided over 1,100 education encounters on topics such as the diagnosis, treatments, associated side effects, and clinical trial opportunities. Next. Our team of clinical oncology social workers are equipped to assist the patient and their families with the many needs that come with a brain tumor diagnosis. We understand that life does not stop when faced with a brain tumor. We can help patients adjust to their new diagnosis, support family communications and difficult care discussions. We can help discuss a fear of a cancer recurrence and survivorship concerns. And we can help locate resources to assist with financial or practical needs. Next. BTN also engages in the local community and has hosted the Brain Tumor Support Group of Northeast Florida since 2007. This monthly support group has served as a resource for over 200 adult patients and their family members in the Northeast Florida area. We can help patients and caregivers locate in-person or virtual support groups in their local communities or on a national basis. Next. We strive to be transparent in our organization. Our most recent survey results indicated that 100% of the individuals who engaged with the Brain Tumor Network were satisfied with the navigational services they received. 94% felt the navigation they received helped them better cope with their diagnosis. 87% indicated the navigation they received helped them feel more empowered to engage in open conversations with their care teams and to participate in shared treatment-related decision-making. And finally, 100% would recommend Brain Tumor Network's navigational services to others. Next. No matter what stage of the cancer journey you are in, you can always contact Brain Tumor Network and we will meet you where you are. You can request a consultation online at braintumornetwork.org or call our toll-free number to connect with a navigator. And before we open the floor for questions, please enjoy the following short video where you will hear from several patients that we've had the privilege of working with over the years.
And now you're about ready to see some people who have experienced firsthand the work from Brain Tumor Network navigators, and they will be telling you their story.
I was diagnosed with a brain tumor in December of 2014. I had debilitating headaches and nobody could kind of figure out what was wrong with me. I happened to be at my parents' house one day and they noticed that I was kind of stumbling around and slurring my speech, and so they took me to the hospital. It turns out I had a brain tumor the size of a peach in my right frontal lobe.
I was diagnosed back in 2015 August with a pituitary adenoma tumor.
I was diagnosed with a grade 2 astrocytoma in my prefrontal cortex, and I had brain surgery to remove it.
We found something, so I'm scheduling you an MRI in the next, the next little bit. And so they do the MRI.
I think I was in 5th grade when they first found out about it. And then I started to have dizzy spells around the time I was 19. That got worse and worse until the brain surgery.
My heart dropped, sank. I really wasn't expecting them to say that she had a mass in her head. And then, of course, immediately they took her up and they kept her at the hospital.
Pit of my stomach dropped.
Yeah, Andrew kind of shut down. We were in the hospital for a week and he lost about 10 pounds that first week just from the shock of it. Spiral into depression and a lot of fear, anxiety. Added to all of that, it was just 2 months before our wedding.
Well, the Brain Tumor Network helped me out a lot, and it gave me courage and strength to talk to others that are going through the same situation that I'm going through to help me.
I actually heard about Brain Tumor Network first from a coworker who has volunteered with the support group for many, many years. But then when we had our first in-office appointment with the oncology team, they brought it up and mentioned it.
So the way we found out about the Brain Tumor Network is we were at his neurology appointment and we looked up and saw a flyer, and we had just been talking about finding a connection for Peter with people who had brain tumors, someone he could relate to and talk to. And we saw the flyer and we called the number and we came to our first meeting, and it was exactly what we needed.
It was actually God sent because this foundation, this organization has helped us through information that we needed, support, just the love and just listening and encouraging.
Just with the people that the Brain Tumor Network got me hooked up with, I felt the anticipation of the surgery was probably the worst part in the weeks beforehand. But once I was actually at the hospital, I just realized I was in really good hands.
I talked with the navigator over the phone, and I don't know what your words to use to describe how it felt, but I'll never forget it.
When I started my oral chemo, I had a lot of questions about the side effects, about the process of getting the pills themselves, that they helped me, they connected me with the organization to get my Temidar.
The other big way that the navigators or the social workers at the BTN helped was in getting medical records when I was trying to apply for Social Security disability for Andrew. They require a significant amount of paperwork, medical records, test results, biopsy results, just countless types of things. And to do my own records requests at every doctor's office or every hospital would have taken a tremendous amount of time.
So we're getting all these just dead ends for 2 years or so, and he was in this network for just a couple of months, and Eden just basically took it by the reins, just give me names, numbers, I'll put everything together, and the next thing you know, we're getting contacted by NIH and setting up appointments for him to be seen there. So it's been an amazing help to us.
My child having a brain tumor was really scary, and information is what really took away that fear.
So anything from diet to actually taking the medication to possible side effects and getting me anti-nausea meds, they definitely helped me with that process, and they were there every step of the way to make sure that I was as comfortable as I could be.
I think to really have help getting to the exact place where you need to be for the proper care is what distinguishes the Brain Tumor Network from the rest of our experiences in the healthcare system across the board.
Thank you so much for your time and attention. And now we will open the floor for any questions.
Thank you so much, Stephanie and Eden. Just as a reminder, if you do have any questions for the Brain Tumor Network, please type and submit it using the Q&A box at the bottom of your control panel on Zoom, and we'll answer as many questions as possible. So it looks like the first question we have here is on clinical trials. For patients living in states such as Iowa, South Dakota, North Dakota, places where there really aren't that many options for clinical trials, especially immunotherapy focused, what are some suggestions you have for them if they're interested in participating in a clinical trial like an immunotherapy trial, but might not have access to one in their immediate area?
Thank you. That's a wonderful question. Well, to start with that, we would try to get some background information on the patient. What are their geographical limitations, who they are working with for their care team. And then we would try to go from there. Most likely we would request some sort of medical record so that we could see, what the patient may or may not qualify for in terms of clinical trials, and then guide them with specific questions to their care team members.
Thank you. We have a couple attendees here who are wondering if the Brain Tumor Network provides support for non-cancerous tumors or benign tumors as well as malignant.
Thank you. That's a great question. And we serve many patients with both non-malignant and malignant tumors. So yes, we provide those services across the range of diagnoses, and we're happy to help with the needs and recognize that there are additional needs that exist for those with benign tumors as well, and we're happy to assist.
Wonderful. Thank you so much. Is the Brain Tumor Networks, are there support services available in cities across the country? Is this something that patients living anywhere can access?
Thank you. I'm happy to answer this question. Yes, we reach patients all throughout the country, even in areas where there are not a lot of support resources for that patient, depending on their diagnosis. We have been very successful in connecting patients with different support programs throughout the country, even if it's through a virtual platform. So yes, even if there's not direct resources in your community, we can assist with that.
Thank you so much. Now, you had mentioned support groups throughout the U.S. that Brain Tumor Network offers. How can a patient or a caregiver who's looking for a support group in their area find one? Does Brain Tumor Network have a support group listing that they can access online?
Thank you. We partner with numerous support groups across the nation. So while we do not have an active listing located on our website, we are able to reach out, and we will connect you and help you locate a support program or group, whether in person or meeting virtually near you and within your city. Thank you.
Thank you so much. And I do just want to mention to any attendees that are looking for support groups in their area, the ABTA does have a support group locator online, so please feel free to use that. You can just enter in your state and it'll show you a listing of any support groups that are within your vicinity. Now, another question we have here is, do you offer support for pediatric patients as well, for children? One of our attendees has a 2-year-old grandson with an anaplastic oligodendroglioma.
Thank you. I'm so sorry for your grandchild. Currently, we serve adult patients throughout the United States, but when we do have requests from pediatric patients, we never turn them away without directing them to either a pediatric group to connect with, or we find whatever resources that they need and help guide them that way. But you know, most of the Brain Tumor Network services are for adult brain tumor patients.
And Stephanie, when you mention adult patients, does that encompass young adults as well? Is it 18 and over?
Yes.
Thank you. And does Brain Tumor Network provide support for those patients who are further down the road? You know, it might have been years from their initial diagnosis and treatment, but now they're experiencing maybe some late effects or worsening in their condition?
Yes, we certainly do, and we can consider that a pivotal time. So we're happy to assist when there's identified recurrence, and certainly we provide a continuum of the services from initial diagnosis all the way through multiple time points. So yes, we're available during those times as well.
That's great to hear. Thank you so much. Given COVID-19, are either of you aware of any barriers or additional barriers that patients are coming across when trying to access clinical trials?
How much time do we have? Because we could go on and on with this. Yes, and this is a constantly changing topic that we're, you know, as COVID is developing and continuing to go on. When it first happened, we did have quite a few barriers for our patients trying to locate clinical trials. They weren't able to cross state lines. Many clinical trial sites had to temporarily halt enrollment. And so challenges are constantly changing. that we're just dealing with as they come. But yes, to answer the question, we definitely have had some difficulty for some of our patients due to COVID and getting access to clinical trials.
Thank you so much. I think we'll take one more question, and this question is in regards to how far your services expand. So we talked a lot about the support you provide in US. Does this go beyond the US? Is there support available for patients in Canada, for example, or any other countries?
Well, our services are, primarily our mission is to serve the needs of those individuals residing in the United States, but we will not turn anyone away. So we're connected. One of our partners, as we mentioned, is an International Brain Tumor Association, and we will do our best to get those individuals who are living outside of the country connected with any organizations that might assist them.
Thank you so much. That is all the time that we have for questions for the Brain Tumor Network. Thank you again, Stephanie and Eden, for joining us. We'll turn it over to Emily.
Thank you.
Thank you.
Thank you so much, Stephanie and Eden. And thank you to all of you who asked those important questions. For those of you who need a quick break, please take this opportunity to stand up and stretch your legs, go get a beverage. But we invite the rest of you to stay on and hear from our sponsor, Orbis Therapeutics. We will be back in exactly 8 minutes at 11:20 to hear our next session on how science impacts brain tumor patient care. Thank you so much.
Good morning, everyone. My name is Kartik Isola, and I'm the Director of Medical Affairs with Orbis Therapeutics. Today, I would like to speak a little bit about the STELLAR study, our ongoing phase 3 trial for patients with recurrent anaplastic astrocytoma. Unfortunately, the survival rate for patients with grade 3 anaplastic astrocytoma has not significantly changed over the last 30 years. Patients with AA have few treatment options with limited efficacy and significant side effects. Once a patient has been newly diagnosed with AA, the current treatment protocol includes surgery to remove as much of the tumor as possible, followed by radiation and either concurrent or adjuvant temozolomide. At the time of recurrence, there are even fewer options. While there are very few drugs approved for the treatment of brain tumors, drugs currently available all have similar mechanisms of action in that most of them are alkylating agents. Our drug, eflornithine, is unique because while the others are cytotoxic, which means that they seek to kill cancer, eflornithine is a cytostatic agent, which means it is tasked with stopping or slowing it from growing by blocking ODC, or ornithine decarboxylase, and inhibiting cell growth and proliferation. The history of eflornithine is robust, with 390 patient exposures with multiple phase 1, 2, and 3 trials having been completed with promising results. The STELLAR study is a phase 3 trial looking to evaluate eflornithine plus lomustine versus lomustine alone in patients with recurrent AA who have failed radiation and temozolomide in the upfront setting. In order to be considered eligible, patients must be diagnosed with grade 3 anaplastic astrocytoma and have recently experienced their first tumor progression or recurrence. They would also need to have completed radiation and temozolomide in the first-line setting. We have currently enrolled approximately 250 patients across almost 90 centers in 8 countries, spanning North America and Western Europe. If you think that you or someone you know may be a potential candidate, please speak to your treating physician. And for more information, please visit www.stellarstudy.com.
Welcome back, everybody. I hope you enjoyed your short break. I would now like to welcome our co-chair, Dr. Mark Gilbert, who will introduce our next speaker.
Thank you, Emily, and welcome back. It's my great pleasure to introduce the speaker, Dr. Sean Harvey-Jumper, who will be talking about Bench to Bedside, how science impacts brain tumor patient care. You'll learn how We take the basic science research and how medical professionals apply this knowledge to brain tumor treatment and care. Dr. Harvey Jumper is an associate professor in the Department of Neurological Surgery and principal investigator in the Brain Tumor Center at the University of California, San Francisco. His own research focuses on the bidirectional mechanisms by which low and high-grade gliomas interface with functional cognitive networks. I should tell everyone that we did ask the speakers for an interesting or fun fact about themselves, and Sean told me that he's an amateur geologist and likes to go on trips with his family to collect rocks and minerals. He states it's a great activity to do with kids. So without further ado, I invite Dr. Harvey Jumper to talk to us about bench to bedside.
Thank you so much for the introduction, Dr. Gilbert, and good morning, ABTA family. It's really a privilege to spend time with you today. As mentioned, my name is Sean Harvey Jumper. I'm a neurosurgeon researcher at UCSF Brain Tumor Center. And I think this is a really unique opportunity to review and walk through how we get concepts from the lab and into the hands of your doctors, and how new understanding and new treatments for disease really take shape. And sometimes they work really well as we planned, and sometimes they don't go as planned. And we'll walk through the history of some of that today. Next slide, please. I have no disclosures, and here's a list of my research programs funding sources. Next slide, please. So we'll cover 4 main topics today. And as we think about how to wrap our minds around this topic and we understand our goal of talking about bench to bedside and innovations, I think we have to talk about where we've come from and a little bit of history in order to understand where we're going or where we hope to go in the future. And so we'll talk and start with a bit of the history of neuro-oncology and neuroscience in general. We'll talk about some of the challenges of translating innovations from model systems into therapeutics, into therapies that your doctor can treat and offer as treatment, as either standard of care or investigational. We'll talk about some obstacles that we have to overcome in this process. And along the way, we'll actually spend a couple of slides talking about how we as non-scientists can look at scientific data that may be interesting to us and try to interpret it for ourselves to stay as well informed as we can be about some of these really important and sometimes difficult to understand concepts. Next slide, please. So in order to understand where we are, again, let's start. Oh, I'm sorry, next slide, please, the history slide. So in order to understand where we are, let's start with where we've come from. And really, the advances in neuro-oncology are closely tied together with advances in history of neuroscience in general, particularly neuroimaging. It's hard to diagnose what you can't see. And so you'll see here that even as early as the 1800s, brain imaging was discovered using blood flow, mental chromography, ways of measuring blood flow in the human brain, initially in animals and then translated into humans. As early as the 1960s and 70s, we started to look at commercial use and regular use of CT imaging and then MRIs in the brain. And that's really where we started to have a real increase in the number of patients diagnosed with brain tumors, particularly because we could see them, and before it was really hard to do. Next slide, please. But in this history of neuro-oncology, and you can see that it shows a number of kind of landmark therapies and new ways of thinking that have come up along the years, including CT and MRI imaging. There could be thousands more of marks along this calendar, along this timeline, of truly innovative concepts that have come up. And to highlight a few, there's temozolomide initially for recurrent disease, but then newly diagnosed glioblastoma in 2006 as standard of care. There's Avastin used for both recurrent and newly diagnosed patients with glioblastoma, now mostly patients with recurrent glioblastoma, even Tumor Treating Fields recently, and as well as others. But in this history, there are so many treatments that don't make the list and they don't end up becoming major advances. And why is that? And I know as a patient or a caregiver that may be frustrating to see, and I think it's important that we try to dissect and think about why this may be. And I think to appreciate this, we have to talk about and think about when translation breaks down and what are some of the challenges. Next slide, please. You can advance one more slide. And as we think about this important concept, you know, there are a number of challenges to translation, but really four main challenges that I want to focus on today. One is the idea of model systems. We study a disease in one type of organism, and we treat it in another, meaning humans. The challenge of treatment resistance, meaning maybe the treatment worked, but tumors are smarter, and they find ways that the body finds ways so that the treatment doesn't work any longer. Third is delivery. The brain is organized in such a way that sometimes getting agents to the brain can be quite difficult. And fourth, differences in associations and causes. We'll break that concept down in a minute. So let's move on to our next slide, and we'll talk about each of these individually. So this is kind of in some ways, a silly slide, but it really highlights the way that we study disease. So if you look at this line here, we start off by studying disease in model systems. So in order to better understand disease and apply these findings to treatments, we have to develop model systems, ways of studying the disease efficiently. That means we study a problem or a disease in very controlled environments, which gives us relatively rapid results in a controlled environment. However, in these studies using, for example, cell culture, as you'll see on the left side of the screen, even moving up to more complicated types of cell culture, these lower organisms that may be physiologically relevant, may not be physiologically relevant, even though they're biologically similar. And so you can appreciate differences in between each of these organisms as we use and look at all of these model systems, from 2D cell culture to fruit flies to zebrafish, mice, and even sometimes dogs or other canines with disease versus humans. Very different organ systems. Very different organisms, but all have distinct strengths and weaknesses. On the right side of the screen, they may be physiologically more relevant. On the left side of the screen, you have more controlled environments with quicker results. Next slide, please. But probably the most commonly used model system to study brain tumors is really centered around rodents, particularly mice. In this slide here, you can see the difference between a human brain and a mouse brain. So even if you consider the issue of scale, our brains are just much more complex and organized than a mouse brain. So a mouse brain, for example, has very few neurons and connections in comparison to a human brain. Our brains are variable. The environments we live in are variable. There's differences between different areas of the brain and areas of the tumor. Our brains have over 1 billion neurons and over 1 trillion neural network connections, which is just very different from the organisms that we study in, which can then pose a problem or a challenge when we try to translate a treatment from one step to the next. Next slide, please. Our next challenge to overcome is really mechanisms of treatment resistance. That means that maybe the treatment works, but the tumor has found a way to outsmart it. So one of the hallmarks of treatments for brain tumors and cancers in general is really the use of DNA damage. That means that our chemotherapy agent and our radiation creates breaks or damage to DNA, and it creates a hazardous environment for the cells, which in turn makes the cells die. And we know that creating DNA damage, again, is a standard really treatment for alkylating chemotherapy agents, including temozolomide. This agent temozolomide that many of us are familiar with, you can see is given by mouth. It's a DNA alkylating agent, and we know that it improves survival when treated with radiation as well, and has nearly a 2-fold increase in the 2-year survival, which is great. But if you look at the cartoon at the bottom of the screen, if you take a bunch of tumor cells When you treat them with radiation and temozolomide, radiation is a little lightning bolt, you can see that most of the cells will often die, but some of those orange cells may have a gene in there that codes for proteins or enzymes that makes it so that they can repair that damage so they can withstand the treatment. And they may be stunned for a while, but eventually they can grow back. That's called temozolomide resistance or treatment resistance. And that is a challenge that has to be overcome many times in translating therapies. It works initially many times, but it can stop working over time. Next slide, please. So the third challenge in getting treatments from the lab and into your doctor's hands is really based on the way our brains are organized. You can see on this slide here that our brains are really designed, unlike other organisms, with really tight blood vessels so that not many substances can actually get in. And that's really protection. We don't want many substances from the environment to get into our brains. That's called a blood-brain barrier. So in general, this protects us from the hazardous effects of the environment around us, but many times can also make chemotherapy agents difficult to get into the brain and through and past these tight junctions, these connections between the cells and the blood vessel wall. As you can see here, sometimes the blood tumor barrier is a little different from the blood-brain barrier, but the same concept applies. It can be really hard to get treatments through that barrier. Next slide, please. So in neuro-oncology, we've come up with a number of ways to try to deliver therapies bypassing that blood-brain barrier. They gave some examples here. So to get around this, we've developed a number of techniques. Focus ultrasound and laser interstitial therapy are a couple of examples. These are terms that are used to describe techniques where we can disrupt the blood-brain barrier so that we can deliver a drug either intravenously or directly into the brain. You can deliver substances into the cerebrospinal fluid. It's a way of bypassing that barrier. We can leave drug-infused wafers or drug-infused tablets into the resection cavity. We call those chemotherapy wafers. We even have options such as convection-enhanced delivery, which involves a slow infusion of a drug, which can then slowly permeate through the tissues at a pretty long distance to get the treatment into the brain and where it needs to be. Next slide, please. And the last concept I just want to touch on is this difference between causation and correlation. And then it's kind of a complicated topic at times, but there in science and including brain tumor research is often made a connection between things that are associated. One event is connected to another event, which is great. That really helps us in understanding a problem. But it can be confusing when we try to make that causal, meaning just because two events, one treatment with one outcome are associated doesn't mean that they're cause and effect. And that lack of cause and effect can sometimes lead us down in different pathways to try to understand treatments because there was never really a strong causal link to something, just an association. Things were linked to each other without necessarily one being the cause for the other. Next slide. So because of these challenges, it can be difficult to apply what we've learned in the lab immediately to patient care. But we have in many, many situations and circumstances, despite these challenges, been able to get treatments that work and work really well for patients. And this is a lot of hard work from many different people. And in this journey, we're faced with mountains of evidence and data that we have to interpret and navigate our way through to try to understand disease for ourselves and for our loved ones and family members. So I think it's important to spend a couple of minutes to walk through how to think about and interpret scientific data as a non-scientist and how we can use, and I'd like to actually use a poster, an actual poster from another meeting to try to walk us through this process. So next slide, please. You'll see this poster here, and I don't necessarily want us to focus on any of the specific details of the poster. This is a picture of a poster that I took at the last Society for Neuro-Oncology meeting. And I gave this put this poster up because it's a poster from a now published paper that was exciting to me. It was interesting to me. And I think that's where this starts. As we're interpreting data in science as non-scientists, it's really important to start with, does this seem like a question that's interesting to me? And you start with the title, and the title can be daunting. So again, this topic title of this poster is called Modulation of Hypersynaptic Microenvironment Differentially Promotes Gliomogenesis Across PIK3CA variants. Again, really long term. And I said that term out loud because I want us to not necessarily focus on the title of the poster. The first thing I would look at when I'm looking at a poster or looking at somebody's research, a particular poster, is the upper left-hand corner. That's going to be the introduction. And in there, you'll find out what the problem is. And you want to think about what the researchers are asking. So what is their specific question? For example, here, their goal is to understand how and why specific types of glioma cells have some cell signaling molecules that make some tumor cells grow. So, okay, that's great. Is this something you're interested in? Is something that seems relevant to you? And if that's the case, then you move on and you keep reading. The next thing you want to read is probably skip down to the methods. And there's one specific part of the methods that you want to think about. You want to understand whether they're using cell culture, animal models, or if this is human data. And I say that because in there, you want to see how closely or relevant this project may be to you at any given time. How important or relevant is this to me? If it's a mouse model, that's great. That's perfectly fine, but it's probably in the preclinical phase and may not be relevant to you anytime soon. In there, if you're still interested, then I would skip down to the summary. And the summary is where the authors will summarize. It's the bottom right-hand corner of the screen, and that's where they'll summarize either by an image or a description what they want you to take away. And those are the relevant points in there. The summaries really can be helpful in helping you understand, again, their take-home points. And the last part I would look at is the author list. And particularly, I would look at the first author and the last author, mostly because if you have other questions, or the topic in the title and the topic in the poster was interesting to you, then many times they'll leave their email address or phone number and you can contact them. Many researchers love engaging with patients and families. And so getting that contact information can be very helpful if you have other questions moving forward. Next slide, please. Great. So now that we've kind of thought about this a little bit more, let's share with some examples in which taking things from the lab and into patient care has worked well, and sometimes where it maybe did not work well. And in that, let's focus on the process, meaning the steps in getting treatments from the bench to the bedside. And in this process, I have to say it's really defined on distinct milestones that we'll talk about. And those milestones are really achieved in collaboration with 4 major stakeholders. First and foremost, stakeholder is you, the patient or family caregiver. Second, is the scientific investigator. Third is the clinician. And fourth, which sometimes gets overlooked and not thought about as much, is industry. And we'll talk about each of those a bit more. Next slide, please. So it takes time to get treatments from the bench to the bedside, and that can be very frustrating. And we'll hear along the way concepts like FDA approval, Food and Drug Administration approval, and what does that mean? So let's talk about this a little bit. So here are the steps. It begins with agent or drug discovery. That includes lab studies, similar to the poster that we just showed, device design, drug synthesis, meaning making the drug, getting ideas of how it's going to be delivered and testing it in animals. And then from there is more preclinical studies where more labs and more people think about this animal testing and what the optimal dose may be in humans. And it's there that we think about concepts like pharmacodynamics and pharmacokinetics. These are complex terms, but really all it means is what does the drug do to the body and what does the body do to the drug? And we have to understand those concepts. concepts like bioavailability, meaning the amount of the drug able to be used by the body. And in the process of all that, we start to learn initially what we think the toxicity may be, even though we may not fully understand it in humans at that point. Then, if the treatment is still promising and we have a mechanistic understanding of how it may work, we start to think about clinical trials. Basic types of clinical trials, there's a phase 1 clinical trial, which is for a small number of patients. And the goal here is really just to make sure the treatment is safe, or what is the safe dose for patients. I should specify. Phase 2 is really with hundreds of patients, and it's really the question is, does the treatment work? Phase 3 is typically for thousands of patients, larger scale, where we really start to understand safety and efficacy. Is it safe and does it work? In there's a process of evaluation, and that's where we start to think about FDA approval. And there, the FDA will look at all the preclinical and the clinical trial data and balance risks and benefits. Do the benefits outweigh the risks? Talk about scaling it, product labeling, quality assurance, and then in the phase 4, we start to think about post-market analysis, meaning get it out into the hands of everybody and make sure that it works for everybody. Next slide, please. So as a surgeon, let's start our bench to bedside examples by talking about how we initially treat patients when they come in. When we first come in, we're diagnosed, many are diagnosed with a brain tumor. We first think about tissue diagnosis and cytoreduction, meaning removal as much as we can. That is the surgery piece. And there's been a pretty important discovery over the last several years, couple of decades really, through a drug called 5-aminolevulinic acid. It also goes by the term Gliolam, or 5-ALA is another term used. And we'll see here that in the late 1990s, we first started to understand 5-ALA use in animals and then extending into humans. But it was in 2006 that a landmark multi-center clinical trial in Europe showed 5-aminolevulinic acid compared to standard surgery use, meaning if we give the drug to a patient prior to surgery and use the drug to try to visualize tumor, we can improve we could prove the amount of tumor removed and something called progression-free survival, the amount of time before the tumor recurs. So that was really exciting. That phase 3 trial resulted in approval of the drug in Europe in 2007. And then the process of translating that to the United States took up several years. First FDA approval meetings in the United States in 2011, and then some investigational use in the United States, and then ultimately approval in 2017. And this was all for the point of better visualization and offering a more complete surgery. Next slide, please. To offer more specifics, you can see here in this, give you the example of the paper. This is a 2006 clinical trial, which showed that if you randomize patients offering regular white light surgery as the black bar in the center part of the figure, compared with patients who received the drug, that's the red line, and you look across the 50% progression-free survival mark about halfway down the figure, you can see that the red line is further to the right than the black line. That means that the time that a patient survives and the amount of tumor removed is better using this drug. And that's great. Because of that study, again, we started investigational use of this agent here in the United States. UCSF, among other centers, had a 5-ALA clinical trial. Next slide, please. And I have to highlight the fact that that clinical trial was very successful and ultimately contributed to FDA approval of the drug, which was great. But it also made us and other centers start to think about what is the role of maximum resection. And in that process, you can see the result of our paper published last year, which showed that extended resection matters. Great, we already knew that. But also in a subgroup of patients that extended resection of both enhancing and non-enhancing disease improved survival even more. And so again, this process of studying the 5-ALA drug led to other questions that helped us redefine the benefit, the relative benefit of extended resection, and in which population of patients we should think about more complete surgery. So multiple good things happen from these sort of therapies. Next slide, please. So what happens to tissue when it's removed from the brain and we bring it to the lab? It sits in a freezer and we then use it for other molecular studies. And I want to use the bench to bedside example of tissue genomics and classification as a second example. So we all know how brain tumors are diagnosed. They're diagnosed by looking at them under the microscope, and you can compare here a slide that shows normal brain to a low-grade glioma or grade 2 and 3 astrocytoma, and then ultimately a glioblastoma. These slides look different under the microscope. Next slide, please. But tumor banking studies, and this is just an example of a consent process from our UCSF tissue bank, and tumor banking studies allowed groups of researchers to do genomic analysis to look at large-scale, large numbers of patients over many institutions over many years. And from there, next slide, please, we're able to subclassify tumors and profile patients' tumors based on certain genetic changes that seem to result in a better or worse prognosis. So you'll notice here on the slide, genes came or were discovered such as TERT, such as isocitrate dehydrogenase, such as ATRX. The name of these specific genes may be less important than understanding that we then started to understand a marked survival difference based on the tumor molecular profiling for both patients with grade 2 gliomas, grade 3, and grade 4 gliomas. Next slide, please. And these data over years became so convincing that it ultimately ended up being introduced into the molecular characterization of tumors. So now, as of 2016, based on these sorts of studies and these sort of genomic association studies from the lab, we now know and classify tumors not just based on how the cells look under the microscope, but use a layered approach, also thinking about and including in there how the cells look from a tissue molecular characterization standpoint. And so with this understanding, next slide, please. Brain tumors are now reclassified based on both genotype and phenotype, meaning what the cells look like, what the tissue looks like under a microscope, as well as genotype, meaning the genetic alterations of the tumor. So with this enhanced genomic understanding that's moved from the published reports and into prognostication and defining tumor subtype, how may this impact therapeutics? And we know that creating DNA damage is the basis of standard chemotherapy agents such as temozolomide and others, as well as radiation. But we also know that brain tumors are smart, and there are many ways that are found in many genes that can repair this DNA damage. And so new treatments are needed, and we can use maybe targeted treatments based on this genetic understanding of disease that has been improved and expanded upon over the past several years. Next slide, please. So in this process, we can talk about another story, a bench to bedside story, which is the EGFR V3 inhibitor story. That's means the story associated with epidermal growth factor variant 3. This is a cell surface protein containing a specific label called an antigen, and it's expressed in roughly a third, 33% of all glioma patients. And if you look at the left side of the screen, you can see that there are patients with glioblastoma who survive for 1 year or longer after diagnosis. For patients with glioblastoma who survive for 1 year or longer after diagnosis, were found to have a certain expression of this EGFRV3 that was independently associated with survival. Therefore, this is a tumor-specific marker with prognostication ability to it. Maybe it's something we can target for therapy. So there have been a number of studies, including this study here to the left, screen left, the Journal of Clinical Oncology 2010 paper that targeted this agent in a small phase 2 clinical trial that showed improved survival. Next slide, please. However, remember from this slide here that it's more than just small phase 1 and phase 2 studies. We really need to test the drug over hundreds and even thousands of patients. So next slide, please. You have to apply these treatments to multiple centers and larger numbers of patients. And you can see here the 2015 neuro-oncology report that showed how the outcome of the phase 2 clinical trial with 65 patients now showing, again, an improvement in overall and progression-free survival, which is really exciting. So with great enthusiasm, we then embark on large multi-center trials with patients enrolled in a double-blinded manner. And you can see over to the right, the results of a multi-center blinded phase 3 study of over 700 patients. And unfortunately, in this study, there were no differences in survival. So as we worked through the process of translating this data, this laboratory-based research from preclinical development, drug development, into phase 1, phase 2, and then phase 3, there was a disconnect. There was a breakdown. Next step. Next slide, I'm sorry. Could we advance one more slide? Oh, there we go. Thank you. So, I'm sorry. Go back one more, please. Thank you. But even in this process, even with failed clinical trials, that did not work, such as the EGFRV3 trial, phase 3 study, we then take those results back to the lab and we start to think about how to do it better next time. In that study, as well as others, really spawned the advent of larger precision medicine clinical trials. So here's an example of one of several different precision medicine trials. This is a UCSF version called a pilot study testing feasibility of individual therapies for recurrent glioblastoma, run by my colleagues Jennifer Clark and Suzanne Chang. And in here, the goal was to test the feasibility and safety and efficacy of an individualized patient-specific treatment regimen, not just based on one molecular alteration, but several different. So the goal is to offer 2 to 4 different agents given together with sequencing results, because we know now from the results of the early precision medicine type of trials, like the one I shared with you, that we need to understand the pathways involved. We need to have a rapid way of sequencing to understand which pathways are involved. And then we have to have the availability of the drugs to get them to the targeted place that they need to be in a timely manner. So next slide. So with these results, you can see that we have individual treatments. Again, this is an example of a 41-year-old patient. She had a left frontal tumor. The tumor was removed, doing well on standard of care. And then you can see in the middle of the MRIs, a contrast-enhancing ball that's there concerning for recurrence, that's removed. And then we sequence that tumor, get rapid sequencing results, and then we turn those sequencing results into treatments. This patient received a 3-drug cocktail treatment, or really 4-drug treatment, including temozolomide, and has been nearly a year with stable disease since. And we keep plugging away. Next slide. with these sort of studies to try to understand this disease and offer new and better treatments, learning even from the failed studies. So this is the last slide here. Well, I just want to recap what we've covered. We talked about how far we've come in neuro-oncology, how far we still have yet to go, some of the challenges in getting treatments from the lab and into the clinic. We talked about a basic bed tutorial on how to understand clinical and basic research and understand at least a little bit whether it may be relevant for us. And we talked about examples of in that translation when it has gone well and maybe when it has not gone so well. And in this, I have to thank all of you. This is all partnership and collaboration with patients at the center, and it's really all about you and getting treatments to you, to patients and family members in the most timely possible manner. So thank you for the opportunity to speak. And if we have time, I guess, Dr. Gilbert, we can answer some questions. I'm not sure how our time looks.
Thank you so much, Dr. Harvey-Jumper. We do have some time for questions. So just a reminder for our audience, if you do have a question for our speaker here, please type and submit it using the Q&A box at the bottom of your screen. And we'll answer as many questions as we can as time allows. So Doctor, one of the first questions we have here is asking, how do scientists and clinicians decide or determine which results from the lab should go on to clinical trial testing and which should not?
Really good question. So that's multiple steps. So one is feasibility, right? Sometimes the agent has to, the practicalities of the study have to work, meaning that you think we know how it works, and it has to be practical that it can actually pull it off. And I say that, for example, because take, for example, the sequencing studies. The fact that we use these treatments now more readily is based on the fact that the technology is there to make it work. We can sequence tissue fast enough that we could get treatments to patients fast enough for it to matter. So practical is one application. And the second is, the peer review process is really important. And so not everything that is presented will actually end up published or be considered good enough for clinical use. And that's where a group of your peers will come and critically look at your work, many times not even knowing who you are, and then there's a consensus together about whether it is worth moving forward and practical and timely. That's a great
Thank you. Thank you for sharing that. Another question we have is asking, can you share what are some of the most promising research angles currently under study at your center?
Yeah, so there, our center's no different from many others, but one example is the immunotherapy clinical trials are really exciting. We're excited about them here at UCSF as well as many other centers around the country. There are a number of precision targeted therapy clinical trials that are currently enrolling. We're really excited about those. IDH inhibitor trials are really important. Those are very promising. And I guess the last one last category I'll add are the liquid biopsies, meaning we're getting closer to being able to diagnose or at least track disease without having to take pieces of tissue. And I think those are really important concepts that are coming forward that are really exciting, that I know I'm personally excited about right now.
Great. It's wonderful to see how many up and coming projects are being worked on. Another question we have is asking, what's the best way to follow what's happening with these clinical trials and in the laboratory as trials advance through different stages? For example, one of our speakers or attendees is interested in learning where or what trial stage the tumor monorail device is at, for example. So if someone was interested in finding out more about where a certain trial is at, where can they go? Where can they find that information?
There are a number of different that's a great question. So, well, I first have to say clinicaltrials.gov is one option, but that website can be a little cumbersome and a little overwhelming. There are a number of foundations. I know ABTA and I think others, anybody who emails me, I could give you a list as well. There are foundations that have done a really nice job of synthesizing clinical trials availability. The other is really calling a center. If you are close to a specific cancer center, you could call them and see what trials they currently have and that are currently enrolling, because one of the aspects that gets overlooked for many clinical trials is how practical it is for an individual to get from their home to where the trial is enrolling. So starting with your local center and calling them is always a really good place to start. And they can also then many times put you in the right direction if there's another specific therapy you're interested in. There are a list of resources, and we can definitely make that available for sure.
Thank you. That's great advice. Another question here is asking about how long it may typically take for a drug to be approved in the US. I believe one of the slides that you had shared earlier showed that it took 10 years for a drug to be approved in the US. Is that typical? Does it usually take that long? And is it usual for drugs to maybe be approved sooner in Europe versus the US?
Yeah, in both US, Europe, and across the world, it can take some time. It really can. Remember, the Food and Drug Administration and other governing bodies there to protect us, their goal is really to make sure that the treatment is safe and effective. And they can put many clinical trials or many promising therapies through fairly rigorous standards to make sure that it is both safe and effective, particularly safe. And so, yes, 10 years can be it can take 10 years for a drug or an agent to be approved. And that's why it's important to collaborate and work and think through these processes with your clinician. Most neuro-oncologists around the country are going to be and neurosurgeons are going to be very familiar, or at least somewhat familiar with many of the treatments that are in the pipeline. And they can talk to you about where drugs are or agents may be in the pipeline, so that even if you can't see them yet, or they're still in the preclinical world, you can learn about them through these resources.
Great, thank you so much. And can you share with our attendees some of the factors that might influence a patient's ability to be included in a specific clinical trial? Is age a factor? Are there any other known factors that you're aware of?
Every clinical trial has a list of inclusion and exclusion criteria. And that's really to try to take this super variable organism called a human being and make it remove as many variables as you can to try to understand, again, whether it's safe and effective. Unfortunately, sometimes in that process, that limits the number of people that can be enrolled. And so there are kind of socioeconomic and barriers that can limit people being enrolled, but there are also biologic reasons that can limit people's ability to enroll in a trial. And that is particularly true for many of our targeted therapies. For example, a clinical trial that involves a very specific type of molecule, well, your tumor probably has to have that molecule abnormality in your sequencing results. And so there are, again, a number of factors that can make you eligible or not eligible, and they all vary by trial. The last part I would say really is performance status. Again, clinical trial clinicians and researchers really want to know whether the drug is safe and effective. And I keep saying that, but it's so true. And if you have a patient who has a number of either comorbidities or impairments that limit their ability to interact and get around, especially if you think that that could be part of the side effect profile for your drug, you may not have that patient enroll because you don't know whether it's the drug or their underlying medical condition that is causing the symptoms as they are. And so all of these factors together really lead us to sometimes a overly strenuous, overly narrow number of people that can be enrolled, where the goal is to enroll as many people as possible always. So that is a really important question and a tough challenge.
Thank you for sharing that. Another attendee is asking, do you know if there are more trials focused on certain brain tumors over others? For example, does glioblastoma tend to get a lot of attention from clinical trials? How many clinical trials are there for other brain tumors like oligodendroglioma, for example?
Yeah, no, that's a really great question. And you're right, that the person asking the question is dead on. Some trials get more attention than others. Sorry, some disease types get more attention than others, and glioblastoma, because of the number of patients with disease and the lack of advances that have come about over a number of years, tend to get more attention. I will say that over the past few years, the number of clinical trials for patients with brain metastasis and meningiomas, particularly malignant meningiomas, has really increased. I know there are a number of oligodendroglioma specific networks and clinical trials and researchers now, so that has improved as well. So I think that while that fact is true, it is an area that is being improved upon as we speak, recognizing that there are many other disease subtypes out there outside of glioblastoma for sure.
Great, thank you so much. And our clinical trials, are they only available for patients who haven't had any treatment yet, like chemo, surgery, or radiation? Or can a patient who's already had different treatments previously still use a clinical trial in the future?
No, that's a great question. So the answer is both. And again, each trial has its own separate set of inclusion and exclusion criteria, meaning people who can and cannot be enrolled based on their medical history or disease state. So there are many clinical trials designed for patients who are treatment naive, but some clinical trials, predominantly because of the way drugs interact with each other, will exclude patients who have had certain types of prior treatment. One example comes to mind is Avastin, but there are others, and that happens mostly because it would limit the research scientists' ability to understand how the treatment would work. That's the reason they exclude patients in that category.
Thank you so much. Another question is from an attendee here who has noticed that sometimes the results for certain clinical trials aren't posted on clinicaltrials.gov. Do you know where patients and families can find information on results of a given trial?
That's a really great question. And, you know, I think there are efforts made to make sure that those clinicaltrial.gov results sites are updated in a more timely manner. I know that is a work in progress and sometimes may not be perfect. One of the ways I would think about this is really reach out to any investigator in the trial, particularly the principal investigator. You can look through meetings. If you are courageous enough to look through meeting abstracts for ABTA, Society for Neuro-Oncology, etc. But that requires a lot of work on your end, on the patient and caregiver family end. The other way is, again, let your medical team work for you and help you, and the advocacy groups to help you. And either you or the advocacy group or your doctor can reach out to the investigators in the study to figure out where they are now, whether the results have been published, and get that data to you.
Thank you so much. And can you share, what advice would you provide for a patient who might be going through a reoccurrence for their brain tumor and now they're interested in, you know, looking into clinical trials? You know, they may have to travel for treatment as well. What advice do you have for that patient who's now going through a reoccurrence and looking into clinical trials?
Yeah, information is key, but information can be overwhelming. So it's really important to partner with a trusted source to help you get that information. Many times it's your neuro-oncologist, if you have one that you're in close contact with, or your oncologist, if you have someone you're in close contact with. Again, advocacy groups are excellent to help guide you through the process. And more information, as long as you can synthesize that information and it's put in perspective for you, more information is better. So reaching out to people to help you understand where the important or exciting therapies are and where you could be a part of that if you're interested in it, but it's really hard to navigate on your own. So working with your oncologist or an advocacy group or some trusted person to help you is really important.
Thank you so much. And I think we have time for one more question. This question is asking, how is molecular profiling and precision medicine impacting the trajectory of research and clinical trials?
Yeah, no, I think that's a really neat question, and the answer is that it is helping move our understanding of disease in a positive way. Meaning, if we understand the genetic landscape of a tumor or of the brain, we can better understand how to treat it. We still have to overcome the problems of getting treatments to the brain, but starting out with a firm understanding of the molecular basis for disease is really important. And genetic profiling is allowing that, as well as helping us subclassify or stratify tumors in categories where they need to go. Patients with different types of tumors in the past have been previously lumped into one subtype, and we know that's not necessarily true now. So the short answer is it is a really important molecular profiling and genetic analysis have been really important additions to the care and the research profile that is offered for neuro-oncology. And it's helping both on the therapeutic side and the prognostic and diagnostic side, which is really exciting.
That's great to hear. Thank you again so much, Dr. Hervey-Jumper, for your wonderful presentation and for taking the time to answer these great questions. I'm going to turn it back over to Emily so we can move on with the rest of the program.
Thank you.
Thank you so much, Dr. Hervey-Jumper. And just as Ambreen said, thank you to all of you for those wonderful questions. It was definitely an insightful session, and I appreciate all of your engagement throughout the whole entire session. We will now have our lunch session. So during this lunch session, you will hear from our researchers, Drs. Christine O'Connor from Cleveland Clinic and Benjamin Ellingson from the University of California with important scientific updates. You will also hear from our sponsors who have helped support this event: Monteris Medical, Cleveland Clinic, GT Medical Technologies, Advocate Children's Midwest Brain Tumor Center, and Agios Pharmaceuticals. Each sponsor will share what resources they offer to patients. We encourage you to listen in during the lunch session to gain useful information. For those of you who need a break, please take this opportunity to stand up, stretch your legs, use the restroom, go grab some lunch or a drink. Following this lunch session is our next session on the practical approaches to diagnosis and treatment of brain tumors. We will start at 1 p.m. Central Time sharp. Thank you so much, and please enjoy your lunch.
Hello, my name is Marty Emerson. I'm the CEO of Monteris Medical. Monteris is the maker of the NeuroBlate System, a truly minimally invasive, MR-guided laser surgical tool used to ablate primary and metastatic brain tumors. The NeuroBlate procedure is performed under MRI visualization, which allows the surgeon to be very precise in targeting the tumor. Because the NeuroBlate procedure is so minimally invasive, a patient is typically discharged from home in 2 days or less. The NeuroBlate procedure has been used with over 3,000 patients and is supported by very robust clinical data. Monteris Medical understands just how important time is to those patients with brain tumors and to their families. Our objective is to deliver hope and healing for those patients with brain tumors. The following video is a brief overview of the NeuroBlate procedure. If you have additional questions, please contact the ABTA or visit our website, monteris.com. Thank you.
The NeuroBlate System is a minimally invasive, robotically controlled, MRI-guided surgical tool used to selectively destroy or ablate unwanted tissue in the brain using a laser. Laser ablation is possible when a focused area of brain tissue needs to be targeted. Your medical team will perform testing to confirm if you are an appropriate candidate and can discuss any questions you may have related to the procedure. Generally, because it is minimally invasive, the NeuroBlate procedure is well tolerated, has a short recovery time, and requires 1 to 2 stitches to close the incision. Your doctor will advise you of any pre-procedure requirements. You must be able to undergo MRI exposure. Shaving your hair is generally not required. A minimal area of hair may need to be removed. You will receive anesthesia, and you will be asleep during the procedure. The surgeon will create a small opening in the skull about the width of a pencil to allow access for the laser device, which is called a laser probe. The procedure is performed in an MRI machine. While you are in the MRI, the doctor will guide the laser probe through the opening. Because the procedure is MRI guided, the surgeon can see the specific area of the brain to be ablated. The surgeon controls the delivery of laser light energy to the targeted tissue. This laser light heats and destroys the affected tissue. The precise nature of the procedure helps to lessen the likelihood of harm to nearby healthy brain tissue. When you wake up after the procedure, you will have a stitch or two in the skin where the probe was inserted. In general, patients experience a short recovery time with minimally invasive procedures. You will schedule follow-up appointments with your doctor as instructed. Each person's situation is unique. Your doctors are the best qualified to let you know how a procedure may affect your outlook.
At Burkhardt Brain Tumor Neuro-Oncology Center, we have a group of multidisciplinary physicians and nurses who work together very closely to provide the best of care for our patients. Most of our patients become extremely close to us during their diagnosis and their treatment. And medical oncologists generally not only take care of cancer treatments for these patients, but also become their primary physicians. I tell most of my patients that this is a journey that they take on with a group of physicians, nurse providers, and other healthcare workers at Cleveland Clinic. We work very closely with our patients, going over what the treatment plan is, right from diagnosis, talk about various roles of medical therapies as well as radiation oncology treatments. I have brain tumor physicians who just operate on patients with brain tumors every day, and hence are extremely competent at what they do. Our group also includes radiation oncology, as radiation oncology is an important part of therapeutic options for patients with brain tumors. I and my colleagues in neuro-oncology are involved in offering patients medical options, which most of these patients need after surgery and radiation. I and my colleagues also offer our patients clinical trials. Due to limited FDA-approved therapeutic options, clinical trials offer a great avenue for additional therapeutic options for these patients that may not be available at some of the other hospitals. Glioblastoma is the most common type of brain tumor that we see in clinic every day. Despite advancements in treatment options, most patients with glioblastoma only survive 12 to 15 months. One of the first patients I treated actually went on a clinical trial here at Cleveland Clinic. And recently I saw him in clinic, and it was very gratifying to see him coming on his 6th anniversary of his diagnosis. He has not seen any form of treatment in the last 3 years and is leading his life on a routine basis. To me, in the last few visits, he has said this is the most healthy he has ever felt. Every day, taking care of these patients who have these highly complex tumors is extremely gratifying, as usually we develop a very close bond. We see our patients every month, and generally it's a journey I tell my patients that we take on together.
Hi, my name is Corey Thomas. I'm a regional sales director at GT Medical, and I'd like to talk to you today about an innovative therapy for treating brain cancers called GammaTile. GammaTile therapy, a head start in the fight against brain tumors. The indication for use, GammaTile is intended to deliver radiation therapy in patients with newly diagnosed malignant brain tumors and recurrent brain tumors. What is GammaTile therapy? GammaTile therapy is a safe and effective, surgically targeted radiation therapy for patients with brain tumors. It consists of a bioresorbable flexible collagen tile embedded with a radiation source. Tiles are placed within the resection cavity immediately after a brain tumor is removed, and the tile design prevents the radiation sources from touching the brain and maintains proper spacing, both protecting healthy brain tissue and ensuring a consistent, optimized dose of radiation to the tumor cells. Over time, the body naturally reabsorbs the tile. The benefits of GammaTile therapy. GammaTile begins targeting tumor cells immediately at the time of surgery. There is no need to wait for wound healing before starting radiation treatment. Radiation is focused right where it's needed and is delivered consistently. GammaTile is designed to protect healthy brain tissue, limiting side effects of radiation. There is no need for an extra hospital stay or travel for additional ongoing radiation treatments. Treatment happens as you go about your daily life. Immediate treatment is powerful treatment. GammaTile was studied on patients with recurrent high-grade gliomas like a GBM, meningiomas, brain metastases, and more. In the original GammaTile clinical trial, all patients had been previously treated for their tumors, had a recurrence, and then were retreated with surgery and GammaTile. When all tumors are considered together, patients treated with GammaTile had an average of 9.7 additional tumor-free months in the treatment area compared to the previous treatments. Visit GammaTile.com for more information, including patient testimonial videos and frequently asked questions. Thank you for your time.
My name is Christine O'Connor, and I'm an assistant professor at the Cleveland Clinic. I currently hold a 2019 Discovery Grant in memory of George Surgeon, and the title of my talk today is Cytomegalovirus Oncomodulation of the Glioblastoma Tumor Environment. What is cytomegalovirus, or CMV? It's a herpes virus that infects the majority of the population by 40 years of age. But most people become infected as young children. And as you can see here, these kids are very happy and they're playing with their toys, putting their toys in their mouths, putting their toys in their friends' mouths. And it's not surprising that this is how the virus is spread. Virus is shed in fluids, including saliva, as well as urine. But this initial infection is usually inapparent to healthy children or even healthy adults who are infected later in life. CMV infection, like all herpes virus infections, results in one that is lifelong. CMV remains in a silent state, or what we call latent state, in cells of our blood system. And when our immune systems are significantly weakened, the virus can actually reawaken or reactivate. And this leads to what we call lytic infection, or an active infection. And what this means is that new virus is made, and it can infect various cell types and organs, including cells within the glioblastoma tumor microenvironment. CMV expresses what we call oncomodulatory factors in glioblastoma tumor cells, and these factors are shown here. And we say oncomodulatory because CMV doesn't cause glioblastoma, or it doesn't cause cancer, but it modulates the tumor environment to make it more amenable to being a tumor. And our favorite protein is US28, and it's been shown to be involved in 2 of the processes that lead to tumor progression. Our interest lies in US28's involvement in the stem cell niche. Now, glioblastomas are made up of both cancer stem cells as well as non-stem tumor cells. The non-stem tumor cells are those that are sensitive to therapies, so they respond. However, the cancer stem cells, or CSCs, are insensitive or refractory to treatment, so they don't respond to them. And this is a problem because these cancer stem cells can self-renew and repopulate the tumor, and they can give rise to multiple different cell types as these stem cells become more differentiated or more mature. So we were interested in understanding the impact CMV has on stemness. So we took cancer stem cells or non-stem tumor cells and infected them with CMV and asked if the cancer stem cell markers changed. And what we found is that in the cancer stem cells, upon infection, these stem cell markers drastically increased in the 2 examples shown here. So how is CMV impacting these cancer stem cells, and how is US28 more specifically playing a role? So we took wild-type CMV, which expresses US28, or a virus where we deleted US28, and we infected the cancer stem cells with these 2 viruses and assessed how well the virus replicated, as well as how well the cancer stem cells expanded. And what you can see here is that when we delete US28 from the virus, this virus grows less well than the wild-type virus that expresses US28 in the cancer stem cells. Furthermore, Cancer stem cells infected with the wild-type virus show an increase in cancer stem cell population. However, when we delete US28, this is significantly reduced. And this is comparable to what we see in the uninfected population. And this phenotype holds true across a variety of cancer stem cell lines. So while CMV does not cause glioblastoma, infection and US28 expression promotes the stemness and expands CSCs. And we feel that by targeting CMV and more specifically US28, we may be able to attenuate cancer stem cell expansion and proliferation. And this is important because this would limit the cancer stem cell population, leaving fewer cells behind that are refractory to current treatments. And with that, I would like to thank the folks in my lab who've done the work, Ben and Amanda, as well as our colleague and friend here at the Cleveland Clinic, Justin Lathia, whose lab we collaborate with, as well as the folks in his lab who've helped. Thank you for your attention.
Ben Ellingson, I'm a professor of radiology and psychiatry at UCLA, and I'm going to be presenting our 2017 ABTA research collaboration grant that was supported by Humor to Fight the Tumor, entitled Validation of Diffusion MRI as a Predictive Imaging Biomarker for Anti-VEGF Therapies in Recurrent GBM. Upon recurrence, there are a few effective treatments for GBM. Bevacizumab, which is an anti-VEGF therapy, was approved in May 2009 for use in recurrent GBM and has slowly become the standard of care for recurrent GBM in the US. However, results from multi-center studies didn't show an overall survival benefit for these patients, but we hypothesized that a specific subset of patients with recurrent GBM may benefit from bevacizumab and other anti-VEGF therapies. So for the last 10 years, we've been looking for predictive imaging biomarkers in the multi-center setting, and we've identified through both single-center and multi-center studies that diffusion MRI characteristics obtained prior to therapy in recurrent GBM is a strong predictive biomarker for bevacizumab and anti-VEGF therapies. So the goal of this specific project was first to utilize retrospective existing data to confirm this relationship between diffusion MRI and anti-VEGF efficacy. Then the second aim was to confirm or identify biological mechanisms that might be responsible for this. And then the third aim was to prospectively validate or verify in a prospective multi-center clinical trial. So diffusion MRI is obtained clinically, and the measurement is the apparent diffusion coefficient. And in areas of high ADC, we see lower cell density and lower cell packing and lower viscosity. And in areas of lower ADC, we typically see viable, densely packed tumor. We've created a technique where we're using histogram analysis to better model the underlying distribution of diffusion characteristics. And we're specifically interested in this lower diffusion characteristic, ADCL, that we seem to think is more representative of viable tumor. And so we've split patients, and we've identified the optimal threshold as about 1.2, and we split patients into higher or lower risk depending on this threshold. So patients with a lower ADCL are going to have higher risk of shorter overall survival on anti-VEGF therapy, whereas higher ADC would have lower risk. So as part of AIM 1, we pooled together multiple phase 2 trials as both anti-VEGF monotherapy training sets, as well as an independent validation set that included both anti-VEGF monotherapy as well as a systemic chemotherapy monotherapy as a control arm. And results confirm that in anti-VEGF monotherapy that we do see a significant survival advantage in patients with a higher diffusion coefficient, whereas in systemic chemotherapies, we really see no difference in overall survival depending on diffusion characteristics. So as the second aim, we wanted to dig into a potential mechanism for this anti-VEGF efficacy. So in 2012, we noticed that decorin, a glycoprotein, was overexpressed in patients that had this higher diffusion characteristic. Interestingly, decorin modulates the stiffness of the extracellular environment, which may modulate the diffusivity. It also sequesters pro-angiogenic growth factors and other things, which may be responsible for the anti-angiogenic effect. So looking at the TCGA and IVGAP data sets, we were able to confirm the relationship between diffusion MRI measurements and decorin mRNA expression. We were able to create patient-derived xenograft models by phenotyping the patient, identifying the diffusion characteristics, growing the tumors out, and looking at RNA expression within these models. We then biopsied different areas of the tumor in these patients, and we're able to confirm a strong correlation between decorin protein expression and our diffusion characteristics both across patients as well as within the same tumor in patients that got multiple biopsies. Decorin seems to be expressed normally in the tunica adventitia, or the outer layers of the blood vessels, and we were able to confirm that using in situ hybridization and some other techniques. We were able to confirm that Decorin expression is localized to this area of microvascular proliferation around the adjacent blood vessels. And lastly, as part of validation, or part of AIM-3, we validated in a prospective randomized phase 3 trial, the GLOBE trial, looking at bevacizumab monotherapy versus bevacizumab plus BB111, an adenovirus that attacks the vasculature. We were able to show that in bevacizumab monotherapy that our diffusion characteristics were strong predictors of overall survival, independent of tumor size, whereas in the combination therapy, only tumor volume, not diffusion characteristics, were predictive of overall survival. Our next steps here are really to dig into the relationship between Decorin expression itself and anti-VEGF efficacy, to see whether or not we can modulate Decorin expression and change anti-VEGF efficacy in both patients and animal models. So with that, I'd like to thank the American Brain Tumor Association for their funding and my other funding sources, as well as you for your attention. Thank you.
The Midwest Children's Brain Tumor Center is a team of dedicated individuals. We take the most difficult child's case and can take them safely through their treatment. This was established in 1997 when there was no center in the Midwest that put this focused interest on children with brain tumors. It's developed since then, and we've treated hundreds of patients with brain tumors, and it's evolved. The resources that we bring are based on the child's needs, and each child has a little different need, and their families have a little different needs. The multidisciplinary approach is very important because there's no one person that can take care of all the needs of a child with a brain tumor. We need a whole team of doctors, and the nursing staff is superb. We have a wonderful child life staff. We interface with the school system. We meet as a team to discuss each child, and there's about 12 or 13 people around the table, all focused on that particular child. It's a whole approach of creating a healthy environment that will lead to the cure of this child's tumor. I consider it a sacred privilege for me to be able to participate and to be an important part to help your family through whatever this neurosurgical illness or problem is. You can see what we're about today, but I'm real excited about tomorrow. We've got some really neat things in the works. I really believe that we give the best care possible to these children, and it's like how I'd want my child to be taken care of.
Hello, I'm Susan Pandya, and I lead the clinical development program in low-grade gliomas at Agios Pharmaceuticals. Agios is a pioneer in discovering and developing innovative oncology treatments. Agios scientists were the first to discover that a mutation in the metabolic gene, IDH, plays an important role in cancer genesis. They published this groundbreaking research in 2009, and by 2018, Agios had developed 2 FDA-approved oral medicines for patients with IDH mutant acute myeloid leukemia. Bringing these 2 targeted oncology medicines from our labs to patients in less than a decade is unusually fast and is a testament to our commitment to developing novel therapies for patients with diseases that have a high unmet need. We're grateful that we've been able to make a positive impact on the lives of so many patients with AML. More than 10 years ago, we also began our research program in low-grade glioma, applying our expertise in IDH-mutated cancers to brain tumors. Among all the IDH-mutated cancers, gliomas harbor the highest incidence of up to 80%. Glioma presents in varying degrees of tumor aggressiveness, ranging from slower-growing disease known as low-grade glioma to rapidly progressive disease known as high-grade glioma or glioblastoma. common symptoms of glioma include seizures, memory disturbance, sensory impairment, and neurologic deficits. The long-term prognosis is poor, and regardless of treatment, the majority of patients with low-grade glioma will have a recurrent disease that will progress over time. Low-grade glioma can be diagnosed at almost any age, from adolescence onward. It is frequently diagnosed in young adults who are at the prime of their lives, advancing careers or starting families. Agios made a commitment to focus on low-grade glioma research for a number of reasons. First and foremost, because there's tremendous unmet need. There have been no approved therapies for patients with low-grade glioma in over 2 decades. IDH is the most common genetic driver of low-grade glioma, with up to 80% of low-grade glioma patients having an IDH mutation. Nevertheless, no prospective randomized controlled trials evaluating targeted therapy in IDH mutated glioma have ever been conducted until Agios initiated our phase 3 INDIGO study. We're paving a path for progress for these patients. Importantly, molecular testing is now commonplace for all glioma patients. It is part of how the disease is diagnosed and classified. This diagnostic paradigm helps to lay a foundation to enable innovative, genetically targeted therapies like IDH inhibitors to make a difference for patients. Current treatments available to glioma patients include surgery, radiation, and chemotherapy. They're all invasive and not curative. Many low-grade glioma patients make the decision to have their disease monitored closely with imaging, otherwise known as watch and wait, to preserve the quality of their lives for as long as possible before embarking on aggressive treatment approaches that can come with chronic and sometimes disabling side effects. Having sequential therapeutic options is critical to help patients live as long as possible and as well as possible with the disease. The vast majority of glioma research to date has focused on higher grade settings. The lower grade patients who are on a trajectory towards high grade aggressive disease have unfortunately been neglected. Agios is researching whether there is an alternative to watching that may stall the progression of the disease without reducing a patient's quality of life. Vorasidenib is Agios' investigational, first-in-class oral medication being researched as a potential treatment for low-grade glioma. It is a dual inhibitor of both mutant IDH1 and mutant IDH2 and has been confirmed to be brain penetrant. We initiated our first clinical study of vorasidenib in 2015, evaluating it in patients with IDH mutant advanced solid tumors, including glioma. Preliminary results supported ongoing evaluation of vorasidenib in the low-grade glioma population. In 2019, we initiated our pivotal phase 3 INDIGO study of vorasidenib in patients with IDH mutant grade 2 non-enhancing glioma. The goal of the study is to evaluate the efficacy of vorasidenib compared to placebo and determine whether vorasidenib could provide a therapeutic alternative to watch and wait to help control low-grade glioma and potentially delay the need for chemotherapy or radiation therapy. The study is active and currently enrolling subjects. We're working with an international group of motivated and talented glioma experts, advocates, and patients to conduct the INDIGO study. It's a truly remarkable global and holistic effort and exemplifies the importance of collaboration in drug development. We didn't create the study in a vacuum. We interviewed patients and advocates, sought regulatory advice through FDA and EMA, and incorporated some of this input as we developed the study design. For example, based on patient and clinical input, we have added quality of life measures and other symptom assessments. If you're interested in learning more about the study, please visit indigostudy.com. We are grateful to all the patients who are participating in our study, their caregivers, the advocates who are providing input, and the investigators who are running the study. Your efforts are critical to pioneering innovation for patients with glioma. With vorasidenib, the first and only brain-penetrant IDH inhibitor in phase 3 trials for low-grade glioma, we have an opportunity to target a highly prevalent driver mutation early in the disease evolution. We look forward to continuing to advance this important work on behalf of patients who have been waiting too long.
Hello everyone, and welcome back. I hope each of you enjoyed your lunch, had the opportunity to take a break, listen in to our sponsors and researchers, or just got up and was able to stretch your legs. I would now like to welcome our co-chair, Jean Arsbaker, who will introduce our next speaker for our afternoon session. Thank you.
Hello. In our next presentation, you will learn about the approaches to diagnose and treat brain tumors, including recognizing the difference between primary and secondary brain tumors and treatment options. I am honored to introduce my colleague and friend, Dr. Stefania Maraca. She is a neuro-oncologist in the Department of Neurology at the University of Illinois in Chicago. Dr. Maraca specializes in primary brain tumors and neurological complications of cancer. The interesting fact about Dr. Maraca is she is from Kalmata, Greece. Many of you have heard of Kalmata olives, and Dr. Maraca's family live on an olive farm. If you're ever in Greece, you should stop by and get some olives. Please welcome Dr. Maraca.
Thank you, Jean, for the introduction. Hi, everybody. I want to thank ABTA for giving me this opportunity to talk to you today for the practical approaches of diagnosis and treatment for brain tumors. Next slide, please. These are my disclosures. Brain tumors are being categorized in two different big categories. So one of the biggest categories is the metastatic brain tumor. And this is a cancer that has metastasized to the brain, has traveled to the brain from other tumors in our body. And primary brain tumors are tumors which started in the brain, and usually they have the tendency to stay in the brain, so they don't metastasize to other parts of the body. Therefore, we don't need to do CTs of the chest, abdomen, and pelvis. And they're arising for our own primary brain tumor cells. Next slide, please. We're going to talk today for primary brain tumors and not for metastatic brain tumors. And more specifically, we're going to talk for astrocytoma, oligodendroglioma, ependymoma, meningioma, and medulloblastoma. Next slide, please. As you can see on the cartoon on your right side, we have a variety of different primary brain tumors, dependently of which cells they're arising from and which parts of our brain. And we have over 120 different primary brain tumors. The most frequent primary brain tumor is meningioma and represents around 38% of the primary brain tumors, whereas glioblastoma, which is the most frequent malignant tumor, represents around 15% of the primary brain tumors. Next slide. The necessary steps that we need to make to set up a diagnosis, the first most crucial step is surgery. So surgery will give us the opportunity to have a tissue that we can provide to our pathologists, and they can analyze it under the microscope. So they will be able to set up a diagnosis and give a name to this tumor. So our pathologists will analyze it. I'm sorry, one slide before. Our pathologists will review the tissue under the microscope, and the first thing that they're gonna try to define is this tumor from which brain cells this has been derived. Also, they will describe how different the abnormal cells look compared to our normal brain cells, and we call this atypia. And they also will describe how different is the size and the shape of the cells, something we call polymorphism, and how quickly those cells are dividing, something we call mitosis. So those will be terms that you might see on your pathology report. They will run extra testing, like such as staining features of the cells. They will see how those cells will react on those staining tests, and we call it immunohistochemistry. And then we'll also analyze the genetic material of the tumor cells, something we call molecular alteration or mutation, which is the genetic makeup of the tumor. So when the pathologists will review all of those features, they will give a name to this tumor, and they will give this name based on a classification system we use, the WHO classification system. We can all the teams communicate of what type of tumor is in the biology in the course. Next slide, please. WHO classification system for primary brain tumors is a little bit different than the staging system that we might be more familiar for other type of tumors in our body, like the staging system. So staging system is based on the size of the tumor and from the metastasis of the tumor has traveled to any other parts of the body. But for primary brain tumors, we use grading system. Grading system goes from 1 to 4, and from 4 being more faster growing tumor, and grade 1 slower growing tumor. So grade 1 is a slow growth tumor that has cells that they are abnormal, but they look very closer to the normal appearance of the cells. Grade 2 tumor maintains the slow growth pattern, but the cells are looking more abnormal compared to our normal brain cells. Grade 3 is even faster growth, and the cells are actively reproducing more abnormal cells compared to grade 2. And grade 4 tumor, we see some extra features that gives us the sense that this tumor is more aggressive and faster growing. So those features are the abnormal cells, the new blood vessels, cells that the tumor is creating to maintain this rapid growth. And you'll see this on your pathology report as microvascular proliferation. There are also areas of necrosis in the center, that those are dead cells. And that's the term that we use is necrosis. That's typical of grade 4 tumor on glioma's part. Next slide, please. So let us apply this grading system for different types of brain tumors. So glioma, it's a big category of primary brain tumor. And glioma, it's a tumor that arises from our glia cells that there are 4 categories. It's astrocytes, oligodendrocytes, ependymal cells, and microglia. And those are the cells that support system of our brain. So generally speaking, when those tumors are arising from each of those cells, not from microglia, but the other 3, we call it astrocytoma, oligodendroglioma, and ependymoma. Next slide, please. For astrocytomas, when those are grade 1, we use a term that we call it also pilocytic astrocytoma. So pilocytic astrocytoma is a tumor that is more in pediatric population or young adults. And when the astrocytoma is grade 2, you commonly see it as with the term of diffuse astrocytoma. Astrocytoma grade 3, the other term we're using is anaplastic astrocytoma. And grade 3 in general for primary brain tumors, you will see it as being termed as anaplastic. Grade 4 astrocytoma, it's our glioblastoma patients. And oligodendroglioma, it's been divided on grade 2 or grade 3. And oligodendroglioma does not transform to grade 4. There is no category of grade 4 for oligodendrogliomas. Next slide, please. So let us try and practice some of the pictures that our pathologists will see under the microscope and how they will give those different names. So you can see here on your left hand, the astrocytoma grade 2, and your right hand, the oligodendroglioma, or oligos for a short term. You can see the arrows that they are pointing out on the cells of those 2 different tumors. If you can notice, the difference between the left picture and the right picture is how those cells looking alike between them. So you can see on the astrocytoma, they're very polymorphic, meaning their shape and size, they look different to each other, and we call this atypia. Whereas oligodendroglioma, those cells are more uniform looking like. So you see the oval shape with a halo around it, and then you see those branches that we call it chicken wire with small delicate blood vessels. So when our pathologists will see those 2 different pictures, they will get the sense that the left will be more astrocytes that they are creating astrocytoma, and the right are more oligodendrocytes that they are creating oligodendroglioma. Next slide, please. So the previous pictures were grade 2 astros and oligo, whereas these pictures are grade 3. And the difference between grade 2 and grade 3, you can appreciate on those pictures that those cells are more compared to the previous picture. So more cells, they're creating more abnormal cells. So they're faster growing tumors. And that's why we're giving the grade 3 or anaplastic grading of those tumors for astrocytoma and oligodendroglioma. Next slide, please. For glioblastoma or astrocytoma grade 4, we also see additional features. So you see on your left hand with the red arrows, the dead cells that we just mentioned before. This is the necrotic area that's very common for glioblastoma tumors. Another feature is the microvascular proliferation, those abnormal vessels that the tumor is creating to maintain their growth. And these are looking like this red arrow on your right hand picture under the microscope. Next picture, please. Next slide. So there are pathologies for a lot of decades, as was mentioned before by Dr. Harvey Jumper. They were using those pictures, those characteristics to classify the tumors. But they realized that despite those tumors, they look alike, similar in those pictures, they can have different biology and different prognosis. And they realized that genetic material of those tumor cells are very important to define the biology of those tumors. So recently, in 2016, we changed our WHO classification and we integrated the molecular information, the genetic material of the tumor cells, together with these tumor characteristics that we just mentioned under the microscope. Next slide. Those molecular characteristics that are important to set up a diagnosis for gliomas are the IDH1P92 co-deletion and H3K27M. There are additional information with other markers that are listed below that they're not required to set up a diagnosis, but they're very useful of giving us additional information for the biology of these tumors. And we're gonna talk for a few of those on the next slides. Next slide, please. IDH, for those that they remember from biochemistry, is the enzyme that's part of the Krebs cycle. So Krebs cycle is the cycle that produces energy to the cells. IDH enzymes, IDH1 and IDH2, they were often been seen mutated on the brain tumors, and more specifically to low-grade gliomas. And they were part of the regulation and programming of their cells to maintain their growth. As it was mentioned before, around 80% of the low-grade gliomas, they will have mutation of this enzyme. And also higher grade gliomas that they will have this mutation will understand that these tumors were years ago, lower grade glioma has transformed to higher grade glioma. So now the IDH1 and 2 mutation is being performed as part of the diagnostic workup. And it's more important for patients that are below 55, what we commonly see on those brain tumors gliomas. Next slide, please. 1P90Q co-deletion is the molecular marker of oligodendroglioma. So you see on the cartoon below, on your left hand, you can see how a normal chromosome 1 pair and chromosome 19 pair is looking like. P, which is the light blue arm, stands for petite or short arm, and Q is the long arm. In oligodendrogliomas, what is happening is that the 1P part of the chromosome 1 and the 90Q is completely deleted. And we are seeing 100% in all oligodendrogliomas patients. So when that's happening, we're using the term of 1P90Q co-deletion, and now we have to identify this co-deletion in our oligo tumors to set up a diagnosis. Next slide. MGMT, it's not necessary for diagnosis, but you will see it often on your pathology reports. And it's a very important enzyme. The role of this enzyme is to repair the damage on DNA, the errors in DNA. Often you will see MGMT unmethylated or methylated status on the tumors. So what that means is that when it's MGMT methylated, as you can see on the cartoon, because of the methylated alteration, this gene is not getting expressed. So that means that because it's not getting expressed, the different treatments that we're using to alter the DNA of the tumor cells it's more effective because then the MGMT does not go and fix this damage that our chemo drugs are creating on the DNA, and more specifically the temozolomide drug. Next slide. So this gives you a summary for the WHO classification for gliomas at 2016, and that's something that Dr. Harvey Jumper earlier commented on. So you can see on the first arrow, it's still the histology part, which is the pictures that we were looking earlier. And then the second line, you see the IDH status. And on the third line, you see the 1p92 being required to set up the diagnosis for oligos. Oligos will be 100% IDH mutant and 1p92 co-deleted. When we see the term of NOS, that means that we could not get the information of the IDH status and stands for not otherwise specified. Next slide. For other CNS primary brain tumors that we use the WHO classification, among others, we're going to talk for diffuse midline glioma, ependymoma, and meningioma. Diffuse midline glioma, it's a tumor that occurs more on children and young adults and has the H3K27 mutation, which is it's a mutation, a specific gene, the H3F3A. It's a tumor that's arising from the midline structures of our brain that you can see on your right hand on this picture of our brain. So the color one are the middle structures, which is the thalami with the light blue color. The purple color is the brainstem, and the back of our brain, which is more the reddish color, is the cerebellum. So once a glioma tumor is arising from these midline structures and carries the mutation of H3K27M, then this is a totally different entity from other gliomas. Ependymoma is another type of glioma that arises in children and young adults. Most commonly, we see it on the spinal cord. We see it on the posterior fossa or the cerebellum that we mentioned. And rarely, but we still see it. We can see it on the superior compartments of our brain that we call it supradatorial compartment. It can have 3 different grades. The grade 1, which is the subependymoma and myxopapillary ependymoma. It can be grade 2 or classic ependymoma, another term that we're using. And grade 3 tumors is the anaplastic ependymoma. As we mentioned before, again, we realize that different molecular mutations are important to further characterize those tumors. And RELA fusion is one of those, among others, molecular alterations important for these tumors to be more informative for the biology. Meningioma, it's a benign, often tumor. It's arising from this layer that covers the brain and the spine, the meningeal layer. And it's actually the most common primary brain tumor, as we mentioned. We have 3 histologic grades for the meningioma. The grade 1 or grade 2, which is the atypical meningioma. And grade 3, it's less often, but it's our malignant meningioma tumors. Next slide. Medulloblastoma, it's common on the childhood. So it's the most common embryonal tumor of childhood, and rarely we see it on our adult population as well. Similarly with other primary brain tumors, we have the histological criteria, but very importantly, we have to identify those mutations or molecular alterations to categorize them on those 4 different main groups. So we'll understand the biology and tailor the treatment of those tumors. Next slide. So that was a brief description of different primary brain tumors and their classification. So we can move forward now with the treatment, and we'll, in the beginning, more general describe its category itself, and we'll try to tailor different primary brain tumors as well. So we talk about surgery. This is the first step, and it's a very important step to set diagnosis, and it can be a treatment step as well. Radiation treatment, chemotherapy treatment, targeted therapy. We have devices such as the tumor treating fields with the newer treatment. supportive care as well. Those will be the categories I will talk about in the next few slides. Earlier, we talked about the clinical trials, which are the investigational treatments, and Dr. Gilbert as well will talk more for clinical trials tomorrow. And the standard of care treatment is the FDA-approved treatments, which are the treatments that they have been through the clinical trials, so they have been proven to be safe and effective for our patients. Next slide. So surgery, as we mentioned, is the first step for diagnosis and treatment for most of the primary brain tumors. The goal with the surgery is to remove as much as tumor we can possible without damaging important normal brain structures. So we're not gonna have impairment neurologically of our patients. Imaging technology now is helping us to achieve this goal. And often we're gonna use imaging tools such as functional MRI or diffusion tensor tractography that will help us identify where is the tumor in relation with those very important structures in our brain that will control our movement, our speech, or our vision. Types of surgery that you will come across with different terms is gross total resection, subtotal resection, and biopsy. Gross total resection means that we are removing almost the entire visible tumor. Subtotal resection means that we have removed only part of the tumor, and we probably will need to have subtotal resection when this tumor is nearby very important structures in our brain, and we'll not be able to remove it also. We're not gonna damage those areas. Biopsy, it's more of a diagnostic surgery rather than a therapeutic, and it's just removing a very small tissue sample, so we'll provide this to our pathologists to set up a diagnosis. Next slide. With radiation therapy, it involves literally the use of a lot of energy of X-rays or gamma rays, neutrons, and proton. The goal of radiation therapy is to kill the brain tumor cells by damaging their DNA, and in that way we'll slow down or stop the brain tumor growth. Usually the treatment with radiation is over the course of few weeks, and it can be different the time frame depending with the type of primary brain tumor. But we want to do it over the course of these weeks because we want to give small doses every day for our final total dose of radiation. We have new technologies that we are using, such as SRS or stereotactic radiosurgery, which is a very focal radiation to specific small area for our brain, which has the abnormality. Proton beam radiation, it's a treatment that you have heard earlier in the videos that we use it in our younger patients mostly when we want to use a high dose of radiation to the abnormal area and spare the surrounding healthy tissue. And it's a treatment that we're using, a radiation treatment we're using for our young adults or pediatric patients that we want to preserve cognitive impairment that radiation therapy can create. Next slide, please. Chemotherapy, or in other terms, chemo, that you all might heard a lot. The goal with these treatments is to kill divided cells. And oftentimes we use it in a cycle fashion, and that's because those tumor cells, they will divide it in different time points, and we want to cut those different groups of cells that they're dividing on those different time points. You can see different drugs that have been approved for primary brain tumors. Temozolomide is one of the most common chemotherapy that we're using, and you will see it as well written by TMZ, which is the acronym. It's an oral drug, and it's often prescribed for our patients with gliomas, among others. Lomastine, the short version CCNU, it's another oral chemo drug, and we can see it as monotherapy, or we can use it in combination with other drugs, such as bevacizumab or PCV, which is a schema of 3 different drugs, the lomastine, procarbazine, and vincristine, and that's often be used in our oligos patients. Next slide. Targeted therapy, it's a type of treatment that targets specific molecular alteration in tumors, that they use those alterations to drive their growth. Among others, bevacizumab is the one that we see it a lot because it's an FDA-approved treatment for recurrent gliomas and targets those abnormal new blood vessels that we just mentioned. So this is an IV medication. It's been provided every 2 to 3 weeks. Next slide, please. Tumor treating fields is a newer treatment. It's a device, which is a cap that has patches we have in our scalp and has arrays that applies alternating electrical field. And the goal of this treatment is to disrupt the skeleton that the cells are making to facilitate the process of being divided from 1 to 2. So this is a device that is commonly connected with a battery or with electricity, and it's approved for glioblastoma patients. Next slide, please. We're not going to spend so much time on clinical trials. As we mentioned, Dr. Hervé Jumper had a lengthy discussion with you during his presentation, and Dr. Gilbert will discuss tomorrow. But this is a treatment that it's a research study or an organized way to determine if a new treatment or device is safe and effective, and it's more effective compared to our standard of care treatment. Next slide, please. Supportive care management includes all the treatments that we're using to manage the side effects of the tumor and or the treatment that we are administering to our patients. Anti-seizure medications are commonly used because our patients with primary brain tumors, they will often have seizures. Steroids are helpful to reduce the brain swelling caused from the brain tumor itself and the radiation from radiation necrosis, radiation injury to the brain. Pain relievers, we sometimes need to use nausea medications, very important to alleviate the nausea that the chemotherapy drugs can create or as a symptom of the brain tumor itself. And blood thinners might be used when our patients will have blood clots, since there are higher risk of developing blood clots. Next slide. So let us try to apply those treatments on different primary brain tumors. For newly diagnosed low-grade glioma, we want to have maximal safe resection. So we already mentioned that this is the goal is to remove the tumor, the visible tumor, without damaging any areas that are responsible for our functionality. And when we do that, if we'll be able to remove all of the visible tumor out, and our patients will be young, less than 40 years old, a lot of times we'll have this watch and wait approach that was just mentioned, or observation with MRIs. But when our patients are older or they will not be able to achieve the growth of the resection, then most of the oncologists will decide to treat these tumors to reduce the risk of recurrence. So these treatments will be the radiation and the chemotherapy that we talk about. And depending with what type of low-grade glioma it is, we might use temozolomide or the PCV. PCV more often used in oligodendroglioma patients. Next slide, please. For high-grade glioma now, independently of the extension of resection and the age of the patient, we will elect to further after surgery treat those tumors. And we're going to use radiation, that's usually 6 weeks. But for our elderly patients or the patients that they have poor functionality, we might elect to use a shorter course of radiation around 3 weeks. And after radiation, the chemotherapy that will be commonly used from standard of care is the temozolomide or TMZ, together with alternate electrical field treatment for our glioblastoma patients. Next slide, please. For the ependymoma tumors, important factors that will help us decide of what will be the next treatment after surgery, it will be the location of the tumor, if it is a spinal or brainstem or supratentorial tumor. Also the grade of the tumor, if it is grade 1, grade 2, and grade 3, the extension of the resection, if it was gross total, subtotal, or biopsy, and then if those tumors have been disseminated, which means if these tumors has been spread on the spine and on that fluid that surrounds the brain and the spine, the cerebrospinal fluid, or CSF, which is something we can see on our ependymoma tumors. Mainly for our ependymoma tumors, we're using the surgery and radiation treatment. And if these tumors will come back, that will be the time that we use more the systemic treatments. And clinical trials are ongoing to establish the role of those tumors. When the ependymoma tumors will disseminate in the spine and the brain, we will elect of not doing a focal radiation only to the tumor, but we'll need to radiate the whole brain and the spine. Next slide, please. For the meningioma tumors, when they are small and they are not creating symptoms, then we'll elect to observe those tumors. But if they are large or symptomatic, then we'll want to do surgery if that is feasible. So if it is in a location that we can access, then the next step will be surgery. But if that's not the case, then we might need to do radiation therapy with no surgery. If we do surgery, we know the grade of this tumor. That will help us as well to define what will be the next step. So for grade 1 tumors, observation after resection will be feasible. For grade 2 tumors with complete resection, we might elect to observe, or some of the oncologists will decide to do radiation. But for grade 2 tumors with no resection of the whole tumor, and for grade 3, we will want to do radiation. And again, for these tumors, we do have available systemic treatments, but they haven't been so well established for their role. And the majority of those are into clinical trials to try to investigate their safety and effectiveness. Next slide, please. Lastly, for medulloblastoma, the important factors as well to decide for treatment of those tumors is the extension of resection. Those tumors, they have the tendency to disseminate on the spine and the fluid. Also the group of the medulloblastoma will help us define what will be the next step. For those tumors, we want to do radiation to the brain and the spine, something we call craniospinal radiation, despite even if they haven't been disseminated, because we know that these patients are higher risk. And we elect to do chemotherapy during radiation or after radiation, depends on what's the type of tumor and the age of the patient. Next slide, please. So with this, I want to thank you for your attention and for participating in our conference. And more importantly, I want to thank the patients and the family for trusting us for the care of our patients. And I think we'll have time for a few questions.
Thank you so much. We do have some time for questions. Just as a reminder, if you do have any questions, please type and submit it using the Q&A box at the bottom of your control panel, and we'll answer questions as time allows. So Dr. Maraka, one of the first questions we have here is asking about the types of tumors. So is it possible for a patient to have more than one tumor type, or are they typically just diagnosed with one tumor type at a time?
Yeah, that's a good question. So especially for our lower grade tumors, they might have the tendency to transform to higher grade tumors. And sometimes we'll see that there are parts of this brain tumor that will be the higher grade, and part of this tumor that will be the lower grade. So it's more that we can see different type of grades within the same tumor, but it will still be the same type of tumor on the B category.
Thank you for clarifying that. And can you share what are some factors that might trigger a tumor to progress through the different stages, progressing from a grade 2 to a grade 3 or a grade 4?
Yeah, so this is for our primary brain tumors. Most of them, they have this natural course that they might transform from grade 2 to grade 3 and grade 4. They're not the specific they're not specific characteristics that or additional risk factors that will facilitate this transformation. It's more of the nature of this tumor. There are, research studies that they're investigating if specific chemotherapies, they might accelerate this transformation from lower grade to higher grade compared to other chemotherapies by creating extra mutations on the tumor just because they are exposed to treatments. But the well-known established knowledge that we have is just the nature of these tumors.
Thank you. Now, some tumor types, like some smaller meningiomas, they may be asymptomatic. Do you know if there is a size limit of the tumor for when symptoms start showing? Is there a particular size of a tumor that will cause symptoms to occur in a patient?
Yes, that's a great question. So I think it's depending of the size, very important factors, where is this meningioma located? If it can be still small, but it can be in a structure nearby that's very important, like sometimes it can be near our orbit and it goes like vision loss, even though that they are smaller. But if they are far away from the very, very important structures of our brain, then usually when they're on millimeter size, it's unlikely to have symptoms from this meningioma. So it depends from the location, and then when it's far away, the millimeter probably would be a size limit that would not cause any symptoms.
Thank you for sharing that. And sticking with meningiomas for a moment longer, you mentioned meningiomas are typically benign. Can you explain why some meningiomas are considered benign while others are considered malignant?
Yes. So when we see this tumor that has cells that are fast multiply, they're fast dividing, then that gives you a sense that this is more an aggressive tumor. So that's why we will call this malignant tumor. There are a lot of different characteristics that we see in those meningiomas that will make us believe that this is a tumor that has a high risk of recurrence and will define in malignant. One of them is the mitosis that we said, that it's how those cells are being divided. If they look like very atypical with a TPI in the cell, so very different from the normal meningeal layer cells. Also, if they have something we call brain invasion, sometimes it can extend not strictly on this meningeal layer, but can extend to the brain, and that's something that we can see it under the microscope. And if they will have this feature, then we'll call it grade 2, at least meningioma. And some specific subtypes of meningiomas themselves, because we know that they're more aggressive, they have the tendency to grow back, then we'll automatically categorize them as malignant or grade 3 meningioma.
Thank you so much for that answer. Can you tell us a little bit about how a clinician decides when to use targeted therapy versus radiation? Are there any specific factors, tumor location? What do you look for when deciding what is the right form of therapy over another?
Yes, that's a good question. I can have different answers actually. So I think for most of our newly diagnosed tumors, the standard of care treatment will be radiation and some sort of cytotoxic treatment with chemotherapy drugs. And on the recurrent setting, the most common FDA-approved targeted treatment that we have is the bevacizumab. And to decide which form we're gonna use as a treatment, if targeted will be one of the ones I will use, it depends of the size of the tumor, where it has been, the pattern that has been regrowth, the symptoms of the patient, the swelling around. So it's a lot of various different features that we need to analyze to decide what will be the next most appropriate treatment. Now, targeted treatments also are on clinical trials, even upfront in the newly diagnosed tumors and the recurrent setting as well. Dr. Harvey Jumper mentioned for the EGFR, EGFR-V3 targeted treatments that's in clinical trials, among others. And that's yet to be determined if those are more effective than our standard of care treatments.
Thank you. And earlier in your talk, you were discussing oligodendroglioma, and you mentioned that it can be diagnosed at a grade 2 or a grade 3, but you didn't mention grade 4. Is there a grade 4 of oligodendroglioma, or once it progresses past that, is it called something else?
Oligodendrogliomas are grade 2 and grade 3. There's no grade 4 oligodendroglioma.
Thank you for answering that question. So another question here is asking about recurrence. When a patient goes through recurrence, how do you determine what is the right course of treatment for them if they've already had surgery, chemo, and radiation in the past? How do you determine what treatments to give to avoid toxicity or avoid over-treating the patient?
Yes, that's very great question. I think that on the recurrent setting for most of the primary brain tumors, usually we see them being more resistant to treatments that we have available standard of care. So I think we all, the first thing we're thinking if these patients are candidate for a clinical trial that will think that they will benefit and they will be candidates. It's always, as you mentioned, a discussion with our patients about risks and benefits in clinical trials, dependently which phase this drug or treatment is on clinical trial. We might not know what are the side effects or toxicity. So that will be a discussion that we'll have with our patients and will help them decide if they want to go with a standard of care treatment that we know that they are safe and effective, or with a clinical trial if we think that the standard of care treatment it's not very promising. It's a discussion that we'll have to have with our patients, explaining the side effects, benefits, and will be a mutual decision with them and their families.
Thank you so much. Another question here is going back to the classification of different types of gliomas. So you mentioned glioblastoma. Is it just a higher grade of astrocytoma? Are astrocytomas and glioblastomas the same type of tumor? They arrive from the same cell type, is that correct?
Yes, astrocytoma grade 4 is our glioblastoma tumor. So this is the same tumor, which is called glioblastoma, the astrocytoma grade 4.
Thank you so much for clarifying that. And I think we may have time for maybe one or two more questions. So another question we have here is asking, do you know if a brain tumor such as meningioma, if a patient has a history of this tumor type, is it possible that that tumor or maybe the subsequent treatments they go through can cause other types of tumors elsewhere in the body?
So one of the risk factors that we know that can cause, in general, primary brain tumor is the radiation treatment itself. So we commonly see more the younger patients when they're kiddos that will have to do a radiation treatment, that those patients will later, meningioma is the most common brain tumor can arise from radiation. But other primary brain tumors as well can arise later in life from radiation exposure. When radiation's been delivered to the brain, usually it doesn't affect the rest of our body, so we're not at risk of having other types of tumors in the body from radiation. But some of the chemotherapy drugs can actually induce other malignancies, such as some of the chemotherapy drugs, they can cause later leukemia. That's very, very rare, but something that we see, and that's why we are monitoring our patients with blood tests later after exposure to chemotherapy drugs. Certainly, patients that they have type of syndromes that they are prone to create different type of tumors and malignancies are more sensitive than the patients that are not having mutation in the cells, that they are more prone to create those tumors. There are specific syndromes that they can do that.
Thank you so much, Dr. Maraca. That is all the time that we have for questions for this session. Thank you again for all of your questions and for your insight, Dr. Maraca. I'm going to go ahead and turn it back to Emily, and we'll move forward with the rest of our program. Thank you.
Thank you so much, Dr. Maraca, for sharing with us the approaches to diagnosis and treatment options. For those of you who need a quick break, feel free to do so now. We invite the rest of you to stay on to hear from our researchers, one of them which is Dr. Yiping He from Duke University Medical Center. We will start our next session on immunotherapy at 1:50 p.m. Central Time. Thank you so much.
My name is Yiping He from Duke University, and the title of this project is Repurposing Remyelination Drugs for Oligodendroglioma Therapies. This project has been supported by a 2019 Discovery Grant from ABTA in honor of an anonymous family foundation. So, first slide, I'm going to introduce oligodendrocytes. This is My name is Yiping He from Duke University, and the title of this project is Repurposing Remyelination Drugs for Oligodendroglioma Therapies. This project has been supported by a 2019 Discovery Grant from ABTA in honor of an anonymous family foundation. So, first slide, I'm going to introduce oligodendrocytes. This is where oligodendroglioma originates. And in the normal process, oligodendrocytes come from precursor cell called OPC, and these OPC undergo a process of differentiation to become mature, functional oligodendrocytes. And what these oligodendrocytes do is they protect the neurons by forming a neuron coating, as shown in this slide. Now, again, in a normal developmental condition, OPC would undergo differentiation, everything is normal, they form oligodendrocytes. And these cells are not proliferating. The mature cells, they are functional, not duplicating. Now, in the case of oligodendrogliomas, they will abnormal event happens. We call gene mutations. And these mutations would cause the OPC cell to become abnormal, and they would ultimately form oligodendroglioma. These OPC-like tumor cells, they keep proliferating, they keep duplicating, and this is how cancers arise. So the question we ask is, in this oligodendroglioma, the OPC-like tumor cells, they keep proliferating and they fail to differentiate. So can we make them more differentiation, therefore less proliferation? And in this case, we might be able to have the tumor under control. So I'm going to switch gear to talk about another disease called multiple sclerosis in this slide. So MS, multiple sclerosis, this is a neurological disorder caused by demyelination. Therefore, it's a loss of normal oligodendrocytes and loss of neuronal coating, called MS. And recent research has actually identified drugs that can accomplish remyelination. And these drugs actually work by promoting the differentiation of OPCs to become oligodendrocytes, and therefore form to restore the myelination process. So in these projects, the question we were asking is, can we use these remyelination drugs for treating oligodendroglioma, using these drugs to promote the differentiation of the abnormal OPC-like tumor cell to be a little bit more differentiated. So the experiment we have done confirmed that indeed tumor cells responded to a panel of remyelination drugs. And as shown on the right side of this slide, you can see we implant the tumor cell into the mice. And in the untreated animals, you can see those green cells. They were tumor cells after 8 weeks. And after 6 weeks treatment, the untreated mice have the tumor cells are visible, but in the treated animals, you can see the tumor cells were mostly suppressed. So our current research is focusing on understanding how these drugs actually work to promote the somewhat differentiated status of the OPC-like tumor cell, and how can we make them more effective. So this project is supported by ABTA. Currently, we are also supported by the internal grant from the Duke Cancer Institute.
Welcome back. Dr. Mark Gilbert will introduce our next speaker. Thank you.
Thank you, Emily. It's my great pleasure to introduce Dr. Peter Fecci. In this next session with Dr. Fecci, we'll learn about the current state of immunotherapy and its impact on brain tumor treatment. And most importantly, you'll hear about the path to making progress for treating primary and metastatic brain tumors with immunotherapy. Our presenter, Dr. Fecci, is a neurosurgeon and he's Associate Professor of Neurosurgery, Pathology, and Immunology at the Duke University. He also serves as the director of both the Center for Brain and Spine Metastasis and the Brain Tumor Immunotherapy Program. As a neurosurgeon, Dr. Fecci has built one of the country's largest centers for laser interstitial thermal therapy as a minimally invasive option for brain tumors. And on a more personal note, Dr. Fecci informed me that he is a level 3 certified sommelier and the part owner of a wine bar and restaurant in Boston. So a very interesting hobby. And we really appreciate Dr. Fecci speaking to us today on brain tumor immunotherapy. Thank you very much. Peter, you're on.
Okay, do I need to start my video? It says that I can't do that. Aha, never mind. I think I figured it out. Well, thanks everybody for having me, and I appreciate the introduction, Dr. Gilbert. This is meant to be a bit of an introduction to immunotherapy for folks, as well as a talk about some of the things that we're doing to counter the challenges we have with GBM and give you a sense of where the field is headed as far as a direction towards success. Emily, I'm trying to gain control of it, but it doesn't seem like I'm quite there. Got it. Okay. So for a disclosures perspective, I do have consulting agreements with Monteris, and the companies that you see pictured below do provide some support for some of the research that we do in the lab. Talk a little bit about the goals of immunotherapy. What is immunotherapy exactly? Really, the idea here is that we're going to treat cancer a little bit like it's an infection. And so the idea is to train the immune system to recognize what's foreign about a tumor. And really that's not such a crazy idea, because what's foreign about a tumor is really the same thing that what's foreign about infections. There are proteins that are expressed in those tumors and those infections that aren't normally present in the normal human body. And if it's foreign or mutated or different, then your immune system can recognize it as such and can attack. And one of the key additional advantages of immunotherapy is that we develop the capacity to generate immunologic memory, which is that the immune system sees and remembers what it saw once before. And so therefore, once you've stimulated an immune response against, for instance, a cancer, should that cancer attempt to come back down the road, the immune system should be able to come back and prevent that recurrence. What are the types of immunotherapy? This gets a little bit more complicated, but trying to distill it down to some simple concepts here. Passive immunotherapy is really the modes of immunotherapy where we're actually transferring in the immunity or the type of immune response we want a patient to have. So we're delivering the agent that if we then removed it, that immunity would disappear. And that can be antibodies, toxins, T-cell transfers, et cetera. Active immunotherapies are most commonly vaccines. And what that means is that rather than transferring in the immune mechanisms, we're actually developing or building or strengthening the host's active immune response. And so once we remove the immune stimulus, the host itself still has the capacity to generate a response. And then the last type is something that's become very popular, immune checkpoint or inhibitory receptor blockade. And I refer to this as perpetuated immunity because what we're really doing here is removing the natural brakes on the immune response. The next couple of slides are meant to be a little bit of a pictorial review to help people understand some of the basics. So imagine that we began with a tumor cell. That tumor cell, again, must have something different about it. And some of those things can be proteins that are present on the surface of the tumor cell, or might even be secreted by the tumor cell out into the humors of the body. And so these types of either surface or secreted proteins are recognized in turn by the humoral immune response, which is a type of immunity aimed at picking up the things that are outside cells and floating around in the humors of the body, hence the name. And the active ingredient in the humoral immune response are antibodies. And those antibodies recognize whole proteins outside of cells. And once they recognize them, they tend to coat those targets or opsonize. And once those targets are coated by antibodies, that essentially is a marker for destruction for those targets by cells in the immune system, such as neutrophils. On the other side of it, we have cellular immunity. And not all proteins or not all antigens, not all targets in tumor cells are present on the surface or outside the cell. But in general, any protein being produced inside a cell, that cell is accountable to the immune system and to the rest of the body for essentially putting a flag out on its surface and say, hey, look what's going on inside of me and make sure it's okay. And so in this arm of the immune system, any protein being produced inside the cell has to be essentially broken down, processed, and presented on the surface of that cell, including tumor cells, in the context of molecules called MHC molecules. And if you're going to have this mechanism, then of course you need a cell in the immune system that's capable of recognizing antigens that are presented to it in this fashion. And that's where T cells come in. And these T cells have a capacity to recognize peptides that are presented in the context of surface MHC. However, tumor cells, like infections, are pretty smart. And they have the capacity to try to avoid the immune system by downregulating their expression of MHC molecules and hence somewhat hiding from T cells and going unrecognized. We also have our moments where we're clever, and so tumor immunologists have designed ways of bypassing the tumor cell bypass. And so we've done things like produce CAR T cells, which now have the capacity not just to recognize processed antigens, but also have a chimeric receptor made from an antibody on their surface that then links to the T cell killing machinery inside. And so now T cells not only recognize presented antigens, but can also recognize antigens present on the surface, much like an antibody would, and can deliver a kill signal to the tumor in the context of seeing that surface antigen. So moving into the immunotherapy review, it's key to recognize that almost everything that we talk about in immunotherapy centers around the T cell. And we believe that this is, for the most part, the effector arm of the immune response that we want to activate against tumors. Those T cells really get their education from antigen-presenting cells in the immune system called dendritic cells. And so they must be taught by those dendritic cells what their targets are to search and destroy. As such, when we talk about things like vaccines, immunotherapy, what we're really talking about is some way of taking some type of group of targets and trying to deliver them into dendritic cells inside the body. And so we create a variety of different types of vaccines, all with a singular goal of somehow inside the body delivering antigens into dendritic cells so that within the host, they can activate the host T cells to generate an immune response. Those all activation of T cells by dendritic cells, again, occurs in vivo, meaning inside the host. But there are types of immunotherapy that are aimed instead at actually activating T cells outside the host and delivering them back. These are adoptive lymphocyte transfers, which means taking T cells that we want to expand against their targets educating them with dendritic cells or other antigen presentation platforms outside the body, and then delivering those T cells back into a host where they can search and destroy their targets. And then the last class of immunotherapy that we talked about before, or immune checkpoint blockade, is aimed at a couple of molecules that typically are present on the surface of T cells once they've become activated. The most common of those immune checkpoints are CTLA-4 and PD-1, which are mechanisms that permit T cell responses to be turned off after a T cell has been activated to prevent unwanted damage. But of course, then, if you can come in with antibodies to prevent that T cell turnoff by targeting molecules like CTLA-4 and PD-1, you can perpetuate the immune response, prevent it from being turned off, and stimulate stronger anti-tumor immunity. So that gives you a little bit of a broad overview of what immunotherapies can look like. As you'll note, there are a variety of cancers listed on the left here for which immunotherapies have now been FDA approved. Of course, notably absent from that list is GBM, where to date, most of the therapies that we've devised have actually been reasonably unsuccessful. There have been some high-profile ones tried, and we have gone to phase 3 trials with a number of therapeutics, whether those are checkpoint blockade or vaccine platforms. And unfortunately, to date, most of those have been unsuccessful or are still awaiting results. So that being said, why do we continue our focus on immunotherapy, and why in particular are we focused on checkpoint blockade? Well, the key answer really is that we've seen such good success in other cancers. And as some examples of that, this is a paper published a couple of years ago, which highlights some of the success, in particular in melanoma, which has often been the cancer that's responded best to immunotherapies. But this highlights what type of response we're looking for, and which can often be present in other cancers. For those of you who aren't used to seeing a survival curve, that's what's pictured here on the left. Hopefully you can see my little cursor. And what's presented here on the bottom are months of survival since a therapy is given, and what's presented on the left here are the percentage of patients surviving at that time point. Now, this is a study which compared nivolumab, which is an anti-PD-1, which we talked about, checkpoint blockade antibody, and it compares that to a chemotherapy typically administered called dacarbazine. And what you can see is that at about 11 or so months after the initiation of therapy on dacarbazine, about 50% of patients have passed away, making that median survival about 11 months. However, when patients were instead administered nivolumab in this particular study, what you can see is that even a year and a half out, more than 70% of patients are still alive. That survival curve is plateaued, meaning many will be long-term survivors, and median survival is yet to be reached. These are pretty dramatic results, and based on those and even more dramatic results in patients with metastatic melanoma, the Nobel Prize in 2018 in medicine was awarded to 2 physicians who were deemed responsible for having discovered these checkpoint blockade molecules, Dr. Hanju from Japan, having discovered PD-1, and Dr. Jim Allison for having uncovered anti-CTLA-4. I do think it's worthy of note that as a graduate student in John Sampson's lab at Duke, our group was the first to test and show success for these types of checkpoint blockade antibodies in mouse models of brain tumor, studies that we performed in collaboration with Jim Allison prior to him winning the Nobel Prize. So we do have reasons to believe that these will work in our preclinical models. And of course, there's more reason for optimism because we have seen activity in the brain. So it's not that these things won't work in the brain, because we've seen it work with metastatic melanoma. And pictured here is again about a 2-year-old study published in the New England Journal, which showed that when you combine an anti-PD-1 antibody, nivolumab, with an anti-CTLA-4 antibody, ipilimumab, those combined work quite well against melanoma harbored within the brain. In fact, so well, where this was traditionally a few months death sentence, that now at a year out from therapy, more than 80% of patients are still alive. At 30 months, which was at the time when this study was performed, median survival had not even been close to reach, with more than 70% of patients still alive, and essentially what was deemed about 25% of patients demonstrating a complete response. So are there other causes for optimism in the case of GBM? There are, and this is most recently a paper that came out last year, which talked about changing the way we deliver anti-PD-1 antibodies in a way called neoadjuvant. I'll go over the meaning of that in a minute, which does cause some reason for optimism. This was the paper that came out. This was published by the group out in UCLA with collaboration from folks in Boston and New York. And what you can see is that they did see some survival benefit of anti-PD-1 in patients with recurrent glioblastoma, which is often difficult to treat. So how did they accomplish that, and what do we mean by neoadjuvant? Well, it simply has to do with timing of delivery. And if you look at the top graph here, adjuvant immunotherapy is kind of what we typically think about, which is after we do a surgery, i.e. for recurrence in this study, that's when we begin therapy. And in this study, that was with pembrolizumab, which is an anti-PD-1 antibody. And so that treatment begins after a patient has recovered well from surgery. And to date, we have not seen much success using that model. The neoadjuvant model means we start that treatment before surgery and continue it through and after surgery. And simply changing that timing, actually in this particular study, produced a pretty significant survival benefit. And so what you see here in the blue is a survival curve for patients treated with adjuvant anti-PD-1, i.e. after surgery. Whereas in the red, you can see patients treated before surgery with neoadjuvant anti-PD-1. In the adjuvant situation, at about 228 days or so, 228.5 to be precise, about 50% survival was already reached. That median survival doubled to nearly 420 days in patients who were administered neoadjuvant PD-1 blockade. So this, of course, does cause some real reason for optimism, and I'd love to give the confidence that simply changing the timing of our therapies will be all we need to do. I do think it's likely to be a bit more complex than that. But if we're going to move forward, we have to start addressing some of the challenges that are unique to patients with GBM, as well as to patients with tumors situated within the brain. So what are some of those? Well, I've listed them here, and I'll simply go through them superficially just to give you a sense. What makes GBM so difficult? First is a concept of tumor heterogeneity. Well, what does that mean? It means, unfortunately, that no two tumor cells in a GBM look the same. And that means to the immune system as well. And what do I mean by that? Well, if we want a target that we can go after with the immune system, the ideal would be to have that target expressed by every cell on that tumor, so that going after that target means killing every single cell. Unfortunately, in the case of GBM, the best, most specific target we have is present in about 30 to 50% of tumors, and even when present in only about 30 to 50% of cells. And even a surgeon knows that if you cut out 30% of a tumor, you're not liable to get much success. So we need ways to broaden our target field. Low mutational burden, well, how do we get targets? We get targets because mutations happen in tumors and they encode proteins that are different than normal proteins that can be recognized as different by the immune system. And unfortunately, GBM tends to have a lower number of mutations than some other cancers, which unfortunately also means lower numbers of novel targets for the immune system to go after. CNS immune privilege. Well, we know that the immune system in drugs tends to have a little bit of limited access to the brain, and although we know some ways to bypass that, it does present some challenges to us. GBM is known often as a cold tumor, meaning that we don't see it kind of hot and loaded with immune cell infiltrates, which means that there's kind of a poor baseline immune response to that tumor that we try to augment with immunotherapy. It would be better to have a tumor that was heavily infiltrated by the immune system at baseline, so it'd be more kind of fodder for us to work with immunotherapies. And when we look at T cell numbers and T cell function in patients with GBM, both tend to be inhibited by the cancer itself, which does a remarkable job of turning off immune responses, not just locally, but systemically. So I'm a bit biased as an immunotherapist here, and so I tend to focus on that lower half of this list here, all of which amount to basically T cell inadequacies. There's a trouble with the T cell, and if we're going to do better with immunotherapy, we have to learn how to understand these inadequacies and counter them. A few of us are focused on that, and what we've uncovered in recent years is that GBM amongst solid cancers, meaning cancers not in the bloodstream, like lymphoma, but solid cancers can have fairly immunosuppressive effects, and GBM tends to be the worst of those. It really does launch an attack on T cells and on the immune system, and it really does therefore limit the capacity to develop that proper anti-tumor immune response that we want. So what's that problem? Well, the problem, going back to what we talked about before, is that immune-based therapies depend on T cells. Nearly every therapy that we talked about above, whether it was vaccines, CAR T cells, adoptive T cell transfers, checkpoint blockade, they all center about the T cell, whether it's aimed at activating them, perpetuating their activity, or whether the therapy might just be T cells in and of themselves. And if you remember correctly, and when we talk about checkpoint blockade, this is an area where we're really focused. And if we want to talk about what you need for successful checkpoint blockade, well, you need T cells to be present in good numbers. You need those T cells to be getting to the tumor. And then those T cells that are at the tumor, you need them to be activated and functioning properly. So to put it somewhat comically and in a pictorial format, T cells before GBM are really quite happy. They frolic about the body doing their job, searching for infections, searching for cancers, until along comes GBM, which actually does a remarkable job of laying waste to the immune system, creating a virtual wasteland of immunity where really the immune system just is unable to do its job. So what's our answer to that? Well, first we have to admit that it's a problem. And so what I'd like to highlight here is what I call the plight of the T cell in GBM. It's sad, it's scrawny, it's sequestered. And what this is really French for is that I'm about to tell you some of the work that we do and what we're aimed at trying to get rid of here and how we're aimed at trying to improve T cell function. I'll try to make it not too boring, but really it begins by recharacterizing T cell dysfunction. We can't just say T cells don't work. We have to understand why, and we have to group that dysfunction into a new schema. And that's something that our group in particular has worked on over the last few years. And so we've helped to recategorize dysfunction into a variety of terms here. I will definitely not bore you by defining each of these, but I will tell you as a spoiler alert that I'm going to focus on the bottom of two here. One of them is called exhaustion, which is going to be just what it sounds like, and one is going to be called ignorance, which is also just what it sounds like. So what do we mean by that? Well, let's start with exhaustion. For years, we thought that the whole problem with the immune system is that we just had to get T cells to the front door of the tumor and then everything would be okay. But as you can see in this picture too, if you're a Far Side fan, getting them to the front door ain't enough. It doesn't mean getting it in and getting them to do what we need them to do. And part of the problem is that even T cells that show up at the front door and get into the tumor's evolved a variety of mechanisms for shutting those cells down. So you can have all the T cells you want there, but if you don't counteract the ability of the tumor to turn them off, exhaust them, tire them out, then there won't be much benefit. This was a study put forth by who was a grad student in my lab at the time, Carolina. She's since finished her PhD and is now doing a pathology residency at Duke. And this was really a great amount of work that she performed. And I won't give you all the nitty-gritty details, but I'll tell you that it was really the first paper honestly in cancer, not just GBM, to show that what's going on inside that tumor meets all of the criteria for bona fide exhaustion, which is something that was characterized in viral infections years ago. And so we were really the first to show that what's going on inside that tumor is in fact exhaustion. And the problem for GBM is that whatever we put in the mouse, whatever cancer that is, we do see exhaustion. The problem is worse for GBM. So these two tumors here, CT2A and SMA560, are GBMs placed into mice. This is a breast cancer, B16 is melanoma, and LLC is Lewis lung carcinoma. And what you're seeing here is a heat map. So red means bad, blue means maybe okay. And these things on the left here are markers for exhaustion. So if you see a lot of red, that means that there's a lot of exhaustion present. And it doesn't take much to figure out that when you look at the two models of GBM, you're seeing a lot more exhaustion than you are in those other cancers. And therein lies the rub for us who are trying to deliver effective immune responses in GBM. And as such, it's important to note that those exhaustion markers are actually, if you noticed, some of those markers are the checkpoint markers or immune checkpoints that we've talked about before. And so because there are so many of those, not just PD-1 and not just C2A4, but a variety of others present in GBM, simply coming at one of them with an antibody is unliable to do the trick. And this is the CT2A glioma in mice we're talking about, and delivering those therapies that are so effective in a variety of other cancers. In this stringent mouse model of GBM, we can see that really it does nothing, and by 5 or 6 weeks after putting a tumor in, all of the mice are dead despite the therapy. Well, some of the ways around that is to acknowledge that there's a variety of immune checkpoints present in patients with GBM and mice with GBM as well. And so we need to get stronger T cell activation, not just perpetuate activity that doesn't exist. And then we need to target more than one immune checkpoint. There's some cause for optimism here because what we've shown is that targeting multiple immune checkpoints and combining that with a strong T cell activator, in this case, an activator of something called 4-1BB, we can actually get fairly good long-term survival. In this case, 100% in these studies. Now, these are mice. It's a lot easier to cure a mouse. But this is at least a proof of concept to show that we need to do more than simply target one immune checkpoint, which doesn't do much for median survival. Ultimately, though, we need to understand exhaustion better, and so our group is looking at trying to understand the source of that exhaustion. How does a tumor do what it does to T cells? What are the signals it delivers, and how are they delivered? And once we understand that better, and we're starting to get some very good pictures of late, we'll understand what the targets we really need to go after are to prevent that exhaustion in the first place, rather than simply slapping a Band-Aid on it and hoping for the best. Now that's a good transition to the sequestration, which is the other, or ignorance and sequestration, the other type of dysfunction that we work on. Again, this is just what it sounds like. And this was a paper we put out a couple of years ago highlighting what was a fairly unusual discovery, which is that the T cells we so desperately need in GBM can't get to the tumor because they're being sequestered away in lymphoid organs such as bone marrow. And this is not just a phenomenon of GBM, but of other cancers in the brain as well. So what is ignorance? It's just what it sounds like. If a T cell is unaware of its antigen or its target, then it can't do its job. So why might they be unaware? Well, they may just not have experienced it yet. They may not have learned about it. They may be trying to chase them in an area where they can't get to because that site is immune privileged. Or in the case of what I want to talk about, they may be locked away somewhere where they can't get to their target and they never even recognize that it's there. And so this was what we uncovered in GBM, and it began with what was a 40-year-old observation that basically patients with GBM are missing their T cells as those cells disappear from the blood. We had chalked that up along with others for a long time to the therapies that patients were receiving, but it turns out that's not the case. And even before therapy, or even in mice that don't receive therapy, we see those T cells disappear, and we see things like spleens and thymuses, which are lymphoid organs, shriveling away with a disappearance of immune cells from those organs as well. These are spleens and thymuses taken from normal and tumor-bearing mice, and it really isn't hard to see the difference in the size of those organs in these mice that have had tumors placed in their brains. And what we did uncover, as we noted, is that those T cells that were missing, many of them were found locked away in the bone marrow. In fact, in patients with GBM, we could find up to 20-fold increases in the numbers of T cells in their bone marrow. And if they're locked away there, then they can't do their job at the tumor. What was interesting is we found that that accumulation happened anytime you put any kind of tumor in the brain. It's not just GBM. And yet it never happened when we put any of those cancers in other parts of the body, whether that was the flank, the lung, what have you. And so there's something unique about the brain that we need to be aware of. And we think really what it is that the brain has a mechanism for keeping T cells out, and the tumors are simply taking advantage of that and manipulating that to their own benefit. And we have an active group in the lab trying to understand what that phenomenon is and how it comes about. But we did discover what it is about T cells that makes them get locked away. They lose a receptor from their surface that would normally serve as an exit visa that gets them out of the bone marrow and back into the blood, and that receptor is called S1P1. And when they lose that receptor from their surface, they get stuck and they can't get to the tumor. So when we genetically altered mice to put in a receptor that didn't get internalized, that didn't get lost, but stayed stuck on the surface, that didn't have much survival benefit in and of itself, but it did make T cell activating therapies that hadn't worked before start to work a lot better. We had 40% long-term survival when these mice with a stabilized S1P1 were given a T cell activator. And when we added checkpoint blockade with PD-1 inhibition on top of that, you could see much more significant long-term survival in those mice. The problem is that there aren't any drugs right now that exist that are able to kind of fix that receptor on a surface. So we need to build an entirely new cancer strategy. We're pretty fortunate at Duke in that S1P1 is a G protein coupled receptor. And the guy that won the Nobel Prize for discovering G protein coupled receptors, his name is Bob Lefkowitz, and he works in the building right next to me. And so Bob and I have teamed up and we found a target that manipulates this S1P1 and other G protein coupled receptors to prevent their loss. And what's interesting is that we really thought what we were bargaining for was a strategy that would just get T cells out of the bone marrow, and that would just serve as an adjunct to immunotherapies. But it turned out that when we started knocking out one of the targets we were interested in, called beta-arrestin-2, simply knocking that out with no immunotherapy delivered, no other treatment delivered, was sufficient to produce 50% long-term survival in mice with CT2A glioma. And then we thought that this would probably only work in mice with brain tumors where sequestration was active. So far, it's worked in just about every tumor we've tried it in, and it works against cancers, whether they're in the brain or outside of the brain. So what we've landed on is a really novel cancer therapy that represents an entirely new class of agent if we can make a drug. And it doesn't, we said it works on its own, but when we combine it with T-cell activating therapies, we get a synergy, 80, sometimes 90% long-term survival when combining with either a T-cell activator or checkpoint blockade. So now we need a drug, and we've screened thousands and thousands of compounds. We now are down to 6, which is just kind of a coincidence that there's 6 circles in this picture. Didn't do it on purpose, but we do have 6 candidates now that we are in the process of bringing into the mouse to try to understand how those candidates act in vivo, and the hope is to be in clinical trial with one of those in the next year to year and a half. And again, this would represent an entirely new class of anti-cancer compound, one that's not been tried before. So moving forward, what's our summary? Well, as we move forward, we need to acknowledge that there are some challenges in GBM and in patients with brain tumors. We can't shut our eyes to those. We have to address these in organized fashion. And it's all the things we just talked about. Poor delivery of T cells to the central nervous system, inadequate trafficking, potentially because of sequestration, inadequate activation because of immunosuppressive capacities of the tumor, and then these checkpoint or inhibitory checkpoint markers that show up in large numbers on these T cells, reflecting an exhausted state. We need to find ways to counter these problems if we're going to have successful immunotherapies in a tumor that does a better job of dodging the immune system than some of the other cancers we talked about. And I think that it's important to recognize that simply because we haven't had success yet doesn't mean we aren't on the right path. It just means that we need to be a bit more thoughtful, intentional about the things we're doing and the way we're going to address it. In the words of Thomas Edison, I've not failed. I've simply found 10,000 ways that won't work. So I'd like to acknowledge my funding sources as well as my lab and all of our collaborators at Duke. None of the work that we do would be possible without them. And I do hope that we've been able to give you a reasonable oversight of the immune system, the types of immunotherapies, the challenges that they face in cancers with cancers of the brain, whether primary or metastatic, as well as some of the, I think, promising paths forward that are left to us and that are actively being pursued in our group and with others across the country, frankly. So thanks very much, and happy to take any questions.
Thank you so much, Dr. Fecci. So we'll now take questions. As a reminder, again, if you do have questions, please type and submit it using the Q&A box at the bottom of your control panel. So Dr. Fecci, one of the first questions we have here is asking, from a patient's perspective, there's a lot of clinical trials out there exploring immunotherapies. Can you share some advice for the patient as they're trying to choose which treatment or which clinical trial might be right for them?
Yeah, that's a little bit tricky in the sense that experimental therapies are by definition experimental therapies. And if we knew they were going to work before we gave them, then it'd be a lot easier for everybody, frankly, including ourselves and certainly for patients. All clinical trials out there and all experimental therapies have the best of intent. To date, I think that understanding what some of the things that have worked are areas where, putting therapies together, doing something different about the timing of that therapy. Those are some of the areas that I think are very interesting to us on the immunotherapy side of things. Checkpoint blockade, combining it with other therapies and altering when it's delivered. I think those are some arenas where I'd have some cause for promise and optimism, because we're starting to see those successes, not just in the laboratory, but in patients as well. And so I think, if you took some messages from this talk, then you, I think, hopefully saw some of the areas where we're starting to move the needle. and I would focus on trying to be involved in those types of clinical trials. But unfortunately, I can't tell you that I've got the magic bullet that says, oh, it's this study at this place that you should be on. If I knew that, we'd all be sending all of our patients there. So of course, there's a little bit of a roll of the dice, but I do think that those are the kind of facets of an immunotherapy trial you should be looking for.
Thank you so much for sharing that advice. Do you know if a patient has a pre-existing autoimmune disorder, does that make them unable to receive immunotherapy? Is that a barrier for them?
So that's a great question. That will be at the individual discretion of the clinical trialist at a particular institution. And so you have to check the eligibility criteria for an individual study to see whether autoimmunity is an exclusion criterion. What I would say as an interesting point is that oftentimes in immunotherapy trials, breaking tolerance to a tumor often means breaking tolerance to other parts of the body as well, because tumors are made up of self, just like we are. And so a lot of times when immunotherapies are successful, they oftentimes come with some concomitant autoimmunity. Immune responses in the thyroid or the pancreas or the liver. And sometimes there are some people that believe that you need that autoimmunity as a marker for success because it's a marker for having developed a really strong immune response, one that by definition exerts some collateral damage, so to speak. What's interesting and what's not really known is whether or not people with autoimmunity might be better or worse responders to immunotherapies, and it brings up a very interesting question. Many trials will exclude people with autoimmunity because they're worried about side effects of the treatment that could poison the water, so to speak, in assessing how good the drug is. So you'll have to look very carefully. Many of those studies will exclude autoimmunity, but it's at least worth asking each time you see a trial.
Thank you so much for sharing that. Now you talked about using immunotherapies in different types of tumors. We have an attendee here who's asking about the utilization of immunotherapy in meningiomas. Is that something that's done often? Are there trials on immunotherapies for patients with a meningioma?
Not so much, and partly because the majority of meningiomas, now not all of them by any stretch, but the majority of them are resectable and can be cured if taken out and or radiated. The exception to that rule, of course, would be higher grade meningiomas or inaccessible ones. Most clinical trials to date have focused on targeted therapies based on the genomic makeup of meningiomas. I'm not currently aware of any immunotherapy trials for, say, malignant meningioma. That doesn't mean that they don't exist. And if they are out there, I would say that they're most likely going to be targeting the malignant tumors and not, say, the grade 1 tumors.
Thank you. Another question here is asking, what challenges does the blood-brain barrier present when delivering immunotherapy for brain tumor patients?
Excellent question. It does present a challenge. T cells, and particularly activated T cells, do traffic in and out of the CNS and do have access. So T cell-based immunotherapies suffer fewer restrictions in that regard. Antibody-based immunotherapies in particular have a bit more trouble getting across the blood-brain barrier. And so for that reason, you'll often see that when people are delivering antibodies or toxins conjugated to antibodies, that they are often delivered locally, i.e. into a tumor resection cavity at a time of surgery, or potentially into the cerebrospinal fluid. And some people are looking at intrathecal or into the spinal fluid administration of even T-cell therapies like CAR T-cell platforms with some modest success, at least in mice to date. So people are aware of that limitation and do tend to bypass it when possible. But in general, T-cell therapies where T-cells are administered tend to suffer fewer limitations in that regard.
Thank you so much. Another question from one of our attendees here is asking if you can please briefly address some of the major side effects of immunotherapy.
Yeah, the major side effects, as we talked about, tend to be kind of developing a strong active immune response. And in order to kind of break tolerance to a tumor, sometimes that means breaking tolerance to things that might look like normal antigens or are normal antigens in other parts of the body. And so For instance, you saw that combination of ipilimumab and nivolumab that has worked against patients with metastatic melanoma. In clinical trials in patients with GBM, oftentimes there was unacceptable degrees of autoimmunity, hepatitis, pancreatitis, thyroiditis, and the toxicities were too great. And so they ended the arm of the two drugs together and focused just on a single arm with nivolumab. So that tends to be the biggest side effect, is unwanted immune response against things that you need.
Thank you. Based on current research and trials, are you anticipating, or from your perspective, do you see any upcoming changes in standard of care based on these trials and research?
Not for GBM at the immediate moment. Obviously, after the paper that came out of UCLA's group, looking at neoadjuvant administration and seeing what looks like pretty promising results, a lot of folks, our groups included at Duke, are launching into a variety of clinical trial formats, both in metastatic cancers and in primary brain tumors, looking to see if altering the timing of a variety of therapies might be the way to go. So I would say that there is certainly a shift there in people trying to look at this question, since it was probably our best success that we've seen to date. I think the jury is still out, but we will be getting those answers soon. And if we see those types of results repeat frequently, then I imagine you will indeed start to see a shift in the standard of care.
Thank you.
Certainly the standard of care has been altered in brain metastasis, where immunotherapy, particularly in melanoma, has been quite successful. It has had some good successes in lung as well. And so that is a standard of care in certain metastatic cancers. But for GBM, the needle's still moving.
Good to know. Thank you for that clarification. Can we go back for a moment to what you had mentioned about ignorance and sequestration? Can you explain why some brain tumors are more susceptible to ignorance and sequestration?
Say your last question again. I didn't hear that.
Why brain cancers or brain tumors are more susceptible to this?
Yeah, that is a great question. One that we are actively trying to answer, and that I can't tell you definitively what that answer is. But that is about a third of my lab right now is dedicated to addressing that exact question. So we understand that S1P1 loss is what the kind of proximal cause of sequestration is. What we less understand is how you get from tumor to loss of S1P1 on T cells. We have uncovered a variety of things that are of interest, including what cells in the brain might be dictating that, and what the signals are that cause it. But I don't have any definitive answers for you. So I would say try me in a year and hopefully I'll have more information.
Thank you for answering that. Do you know if different genetic syndromes, genetic conditions, do they provide a barrier for patients who want to seek immunotherapy? For example, if someone has Leishman, are they able to use immunotherapy, or is that not recommended?
From a Leishman perspective specifically, I wouldn't understand or imagine any barriers to the use of immunotherapy. Leishman, for people who don't know, is the loss of the p53 tumor suppressor gene, and so people tend to be susceptible to a variety of cancers. There's nothing contraindicating immunotherapy in my mind in Leishman, but I would say the people who are less likely to receive benefits from immunotherapy are people who have genetic syndromes of immune disorders. So syndromes where they're missing large components of their immune systems. Maybe a passive immunotherapy where we're transferring immunity into those folks might be the way to go. But certainly trying to stimulate a strong immune response in someone who has immune deficits would be difficult. Likewise, Dr. Gilbert's group had published a paper talking about the impact of things like steroids, which are very common in patients like GBM patients or brain tumor patients. And steroids are immunosuppressive, and yet they're a staple of controlling symptoms in patients with tumors within their brain. And we just have to be judicious about those things because you're robbing from Peter to pay Paul, et cetera. And so we always have to be cognizant of all of our therapies and what they're doing to the immune responses and whether they might be bootstrapping us.
Thank you so much. I think we have time for maybe just one more question. This one is asking about combining immunotherapies with other treatments. We have one of our attendees here, for example, who's on a trial where they're receiving Keytruda and Optune. Is this common for trials or treatments to be combined in this way with immunotherapies?
It's becoming more common. Part of the issue is that I think you need to have you have to be careful that people aren't just combining things for the sake of combining things. So you want to hear that there's a rationale for why two things should be put together. It shouldn't just be a shotgun approach. And I think that, the people that are at the institutions that are doing the research that are aimed at understanding mechanisms behind immune deficits or that have uncovered the immune mechanisms underlying a therapy, then I think you can feel more confident that therapies deserve to be put together rather than someone just saying, hey, let's just try this. But one thing is very, very clear. The thing that works against GBM or any cancer in the brain is not going to be a magic bullet. It is not going to be one thing. There's just too much variability in these tumors and too much capacity for these tumors to evolve before our eyes. So we've got to hit them on multiple fronts. And so I do think that combination therapies are ultimately going to be the way to go as long as those combinations are rational.
Thank you so much for your time, Dr. Fecci, and for answering these wonderful questions from our attendees. I'm going to go ahead and turn it back to Emily, and we'll move forward to the rest of the program. Thank you again.
Now I'd like to introduce you to Jim Riley, Board of the ABTA Board of Directors.
Welcome back, everyone. The Joel A. Gingras Jr. Foundation has been a longtime partner to the American Brain Tumor Association. When Joel Gingras Jr. passed away from a brain tumor in 1998, the Gingras family decided to dedicate their lives towards helping others fight this disease and formed the Joel A. Gingras Jr. Memorial Foundation. And by doing so, joined the brain tumor movement. Since partnering with the ABTA over 30 years ago, the JAG Fund has donated over $2 million to ABTA research. These funds have drastically impacted the way the ABTA serves the brain tumor community. We thank them for their tireless commitment and partnership. I would like to introduce Martha Gingras Bash, 25-year JAG Fund Board member and chair of the JAG Gala event, to say a few words. Martha?
Thanks, Jim. And I want to say on behalf of my family, appreciate the opportunity to talk and all that the ABTA has done as our partner. To tell you a little bit about our family and Joel Gingras, we are a large family, one of 6. So Joel was my oldest brother. And growing up, it was always interesting, you can imagine, in a fun and busy household. And we have a very close-knit family even to this day. And so when Joel was diagnosed at a very young age of I believe he was 25 at the time. You can imagine how devastating that was to the family. I was 16 at the time, and it's hard in your 16-year-old brain to understand what that means. But I say that as I am now approaching the age that my parents were when we lost Joel, you really feel the impact over your lifetime. I'd like to tell everybody a little bit about Joel, if that's okay. So Emily, if you don't mind putting up the slide of who he was. Because I think knowing a little bit about Joel explains how the JAG Fund came into creation and how we've been able to continue our fundraising efforts, as Jim said, over 30 years, which I believe makes us the longest family-run fundraiser for the ABTA. So Joel was the life of the party. He had a very magnetic personality. He loved to be spending time with friends and hosting parties, golfing, and doing a bunch of things, but they always involved being around a lot of people. One of the main things that Joel did along with my older brother and sister was they used to host a party every summer called the Tube Float. And they had their friends come from all over, from college to come for the party of the year, which is the Tube Float. And it was during that time that Joel was diagnosed with a benign brain tumor, choroid plexus papilloma. And the prognosis at the time was fairly positive. So we felt good about that, but we knew that the Tube Float was coming up, and we decided, the family decided that we'd continue with the party in Joel's honor. It would give an opportunity to friends to see him. And so we did that year while Joel was in the hospital. Sadly, after the fall, Joel passed away from complications due to the brain tumor surgery. And the tube float had been held, but there had also been money raised to help him as a young 20-year-old pay the medical bills for the brain tumor treatment. So after he passed away, there was funding that was left over, and my next oldest brother, Jonathan, started to look for a partner and a place to do something good with the good intentions and the good money that had been raised at our first informal fundraising event. That's really the birth of the JAG Fund, and that's a little bit about who my brother is. If you could change the slide, Emily, I'll show you what we look like now. So we're all a lot older and our family's expanded. And that's partially what I think is the main success of the JAG Fund. It's not just my brothers and sisters and my parents to keep the JAG Fund going, but it's all of the numerous friends and family friends, and most people now that come to the events didn't even know Joel. I think why we decided to dedicate it to raising funds, it kind of happened like by accident, as I mentioned. When we had those funds and we were trying to figure out what to do with them, Jonathan found the American Brain Tumor Association, and that started the partnership, the long-lasting partnership. And I think the gift that the ABTA has given to us is to have a sense of purpose after losing Joel. It is something that inspires us and keeps us going, knowing that the money that we're raising is going to research and all of these wonderful physicians and researchers and clinicians and providers that are helping the families like ours deal with brain tumor diagnosis. The other thing is it allows us to celebrate multiple times a year my brother's memory, and that celebration has been a huge amount of healing for us. So healing for my parents, healing for my siblings and I, and healing for my brother's friends. So even though it's 30 years, it's still, as I mentioned, an impact that happens over and over for your entire life. So 30 years and you will always still feel the impact. I feel right now that it's been a very positive impact, and I'm very, very grateful that we've had the opportunity to do something fun, remember my brother, and really help all of these wonderful people that are dedicated to ending brain tumors. The ABTA partnership to this day, as I mentioned, it's been very helpful for us, very meaningful. When I think about back to when my brother was diagnosed, as I mentioned, I was 16 and my parents were just maybe 50 years old. What did they do when they had that information? What did Joel do? I mean, it was pre-email, it was pre-internet. So I think about that, how scary that must be to get the diagnosis and have no resources to learn more about what that means. And I think what the ABTA does is also allows this amazing caregiver support. I know personally, and through the JAG Fund, we've recommended so many families, when they get that diagnosis, they'll come to us and they're just desperate to find information. Now it's a little easier because you can Google on your own, but there's such a reassurance to know that they have a place to go to get additional information from an organization like the ABTA. So it's a huge, meaningful part of, I think, what you do is providing not only the funding for the research and the development to help us end brain tumors, but the incredible amount of support that you give to families that are dealing with this diagnosis, to the patients and to the families. So I just would like to end with such amazing gratitude to all of you and what you're doing, for the opportunity to talk here today about what the JAG Fund's done. And your work inspires us to keep going. So even though, you know, it's been 30 years, we're all getting a little older, the family's expanding, and each year we wonder, like, how can we keep it going? And especially in a hard year like this year, right, where all events were canceled, the work that you do is what inspires us to keep going. The work, the opportunity to celebrate my brother's life, to extend hope and healing with our family and with all of the families that are part of the American Brain Tumor Association world. So thank you very much for the time. I really appreciate it. And thank you also to the JAG. I won't, spoiler alert, I won't say who the recipient is, but thank you so much for your work as well.
Thank you very much, Martha. Really appreciate you and your family's dedication to the ABTA. In recognition of Ginger's dedication to the cause, the American Brain Tumor Association announced the Joel A. Gingras Award in 2010. The purpose of the Joel A. Gingras Award is to recognize an individual or organization who has significantly contributed to the mission of the American Brain Tumor Association. We are pleased to recognize Dr. Priscilla Brastianos, Director of the Central Nervous System Metastasis Center at Massachusetts General Hospital, Harvard Medical School, as the recipient of the 2020 Joel A. Gingras Jr. Award. Dr. Brastianos first received ABTA funding as a medical student, which helped propel her career in brain tumor research. She's been part of the ABTA community since then and recently played a vital role in our work on brain metastasis. During her fellowship training, she received an ABTA Basic Research Fellowship. With ABTA funding, she made seminal contributions to the field of brain metastasis research, demonstrating that brain metastases genetically diverge from primary tumors and harbor clinically actionable mutations. Dr. Brastianos has mentored several early career scientists who were awarded ABTA fellowships. Her research focus on understanding the genomic mechanisms that drive primary and metastatic brain tumors. She has led studies which have identified novel therapeutic targets in brain tumors and has translated her scientific findings to national multi-center trials. Dr. Brastianos also leads an R01 funded laboratory and a multidisciplinary central nervous system metastasis clinic at Massachusetts General Hospital, Harvard Medical School. She has received a number of awards for her work. Her patients inspire her every day to look for better treatments for patients with brain tumors. Please welcome Dr. Brastianos as she receives her award.
I am truly touched and humbled by this award. Thank you so much to ABTA and the Gingras family for this honor. 60 years ago, my grandmother, one of the only females in her medical school class, palpated a breast mass while learning how to perform physical exams in medical school. She was 23 years old at the time, and she had just diagnosed herself with breast cancer. She went on to practice medicine in a rural area in Greece, even after the cancer had metastasized to her bones. She had a true impact on the people of that region, not only practicing the art of medicine, but also working with several impoverished families to help them cook and sew. 6 years later, at 2 a.m. one night, she fell off her horse while rushing to help with a baby delivery. She suffered multiple fractures because of the cancer in her spine, and she passed away at the age of 29. She left behind my mother, who was 6 at the time. She also left behind a community of families who were touched by her compassion as a healer, and she was remembered decades later. "40 years later, my mother was diagnosed with breast cancer. I was in medical school at Johns Hopkins at that time. And so we started her journey of mastectomies, radiation, and chemotherapy. We lived through the trepidation of awaiting scan results, the anxiety of trips to the emergency room, and the side effects of her chemotherapies. It was these two women woven into my life that inspired me to become a medical oncologist and scientist and look for treatments for metastatic cancer. My mother's strength and valiant battle drives me. With each failure of her chemotherapy, with every day that her tumors were continuing to increase inside, with every day that she was in excruciating pain from the cancer in her bones, I delved deeper into the research that would help her and others with the same disease. My goal is to study and find new therapies in primary and metastatic brain tumors. And ABTA has been instrumental in this pursuit. I received my first medical school grant from the ABTA as a medical student, and then again as a fellow. And now ABTA has funded trainees in the lab. ABTA has provided us with the funds to initiate a massive collaborative effort to study the genomics of primary and metastatic brain tumors. And patients have graciously consented to have their tumor samples used in this research effort from all over the world. And this has been a tremendous multidisciplinary effort. We are using the latest state-of-the-art technologies at the Broad Institute of Harvard and MIT to study the genetics of brain tumors. And this has already led to national trials in meningiomas, craniopharyngiomas, and brain metastases. And most importantly, we are seeing patients benefit from these therapies. And it is because of ABTA's support, as well as the amazing team of collaborators and the brilliant members of my lab, that makes these discoveries possible. My mother passed away 5 years ago from metastatic breast cancer. This is her in her gardens a few months before she died. I miss her every day. I lost the race against her illness. She did not live to see me walk down the aisle. She will never meet her grandchildren or watch our research unfold. The day before she passed away, she asked me to promise to continue my relentless pursuit to finding new therapies. Too many people die of brain tumors. And this is what I'm dedicating my life to. And with ABTA's support, I'm hopeful that we will make great strides. Thank you so much again for this amazing honor.
Thank you so much, Priscilla. You are so deserving to receive this award. We are honored for your contribution to the brain tumor community and looking for better treatments. Welcome back, everyone, for our keynote session with Maria Menounos. I would now like to introduce you to Mindy Plugs, board member and chair of the ABTA Mission Committee, who will introduce our keynote speaker. Welcome, Mindy.
Thank you, Emily. Good afternoon, everyone. I'm Mindy Plugas, a member of the ABTA Board of Directors and chair of the ABTA's Mission Committee. I hope you found today's programming to be informative and emotionally nurturing. We are all here today because we seek a common purpose, a cure for brain tumors. Each of us has our own story that has propelled us to come together to fight this unforgiving disease. For all of the patients, families, and caregivers who are joining us today, the American Brain Tumor Association wants you to know one thing, that you are not alone. The ABTA, the medical community, and the research community rise every day to make your tomorrow better. With that said, it is my honor and privilege to introduce you to our keynote speaker, Maria Menounos, whose story is certain to inspire, encourage, and resonate, whether you are a survivor or a caregiver. Maria is an Emmy Award-winning journalist, author, and actress who has earned numerous achievements throughout her career in the news and entertainment industry. She's been on the line to report breaking news and interview presidential candidates. And now she adds the roles of brain tumor survivor and caregiver. In early 2017, Maria started experiencing symptoms of her own as she was caring for her mother, who was diagnosed with a glioblastoma brain tumor a few months prior. Maria thought it was stress from caregiving. After a visit with her primary care doctor, they decided to get an MRI. The MRI showed Maria had a golf ball-sized meningioma, a brain tumor located in the membrane surrounding the brain and spinal cord. Maria found herself in the unlikely circumstance of going from caregiver to patient. 1 month later, Maria had nearly all of her tumor removed and lives each day with the promise of tomorrows. She's now turned coach and advocate for others fighting brain tumors, all while balancing the demands of her public life on TV and radio. Please welcome Maria Menounos.
Hi, everybody.
Hi, Maria. Thank you for joining us today.
Thanks for having me.
So let's start from the beginning. Maria, tell us a little bit about yourself and what you do.
Well, I'm the daughter of two Greek immigrant parents from Medford, Massachusetts. I'm a huge sports fan, Patriots, Celtics, you know all the winning teams. Of course, as you mentioned, I'm known for various things that I've done in the entertainment industry, whether it's serious reporting with the Today Show or Nightly News, or the fun stuff with, Extra and Access Hollywood and Entertainment Tonight and E, or some WWE time, wrestling in the ring, Dancing with the Stars, and so much more. Yeah.
So you've had a very successful career, and it's at this time when your career is doing so well that you learned that your mother was diagnosed with grade 4 glioblastoma. Tell us how you responded to that news.
Well, I was volunteering at a dog charity at the time, and my dad called me and he said that they were airlifting my mom to another hospital and that they found a tumor. And now I'm on the West Coast, she's on the East Coast, and I just remember collapsing in the parking lot. And I remember going home, and I was supposed to be flying out to London that next day to interview Renee Zellweger for Bridget Jones' Diary 2. And I immediately called my boss and said, I can't come, I have to fly home, and got on a plane. And by that next morning, I got there in the middle of the night. The next morning, the doctor came and visited and said, your mom has stage 4 brain cancer, otherwise known as glioblastoma. And it was just her and I. My dad and my brother had just left to go get some coffee. And my mom just took the news like such a champ. They said, what she had, and she goes, okay. And then he left, and I looked at her, I was like, okay, let's get out of here. And I had already started working in those hours before, talking to a few different doctors. I actually had created a little neurosurgeon team. Dr. Linda Liao from UCLA was on it, and a few others that were helping me with some quick decisions even before I even knew exactly what we were dealing with. But it was pretty paralyzing. You'd never expect to hear anything like that. I mean, brain tumors are rare until you get into this club, which none of us wanted to be a part of. And so it was really challenging, but I had to go into quarterback mode really quickly and produce her care and find her the best doctors. And so that's what we did.
How is she doing now?
She's doing well. I mean, we just celebrated 4 years at the end of August, and we're grateful to be 4 years in. She had the tumor came back last September, basically, and it was bigger than the first time. And so we had to jump into action again because we had been really coasting. The tumor had just been shrinking and shrinking, and it had been stable for so long. But there were some things that just slipped. I feel like with glioblastoma, and hopefully we'll get to this at some point, you have to be so on top of it. And so she started, eating things with more sugar and cheating on the diet. The Optune came off. Certain things happened, and I have to believe that that led to the tumor reinflaming. And so this last year of treatments, she's been on Keytruda and Avastin. It's been taken a lot out of her. So she's happy and she's here, and we're doing the best that we can.
Mm-hmm. To survive a GBM diagnosis for 4 years is very rare. And I think everybody would really be interested if you could share a little bit about the overview of her treatment journey that has contributed to her physical and emotional well-being throughout that time.
Yeah, well, I mean, first of all, I get emotional. Yeah. You never think that you're going to get there, but we are lucky we are here. You know, when she first got diagnosed, the primary focus was who is going to operate. And so I encourage everyone always to get multiple opinions. My mom went with Dr. Keith Black at Cedars-Sinai. He operated on both of us, actually. And of course, he's the best. So, and we love him. He's a part of the family now. And so we started with the traditional path, which is, you know, chemo, radiation, surgery. They didn't get a full resection, but, you know, soon after we started all those treatments. And then within a short amount of time, they thought the tumor was growing back. And so what I had done is I created a board, and that consisted of Dr. Reardon at Dana-Farber, who helps us when she's on the East Coast, Dr. Friedman over at Duke, and of course, our neurosurgeon team at Cedars, to bounce ideas off of everybody. And everybody had very differing opinions of what to do at the time. And her oncologist, Dr. Rudnick, was kind of looking at it, and he's like, well, this could be pseudo-progression. You're panicked, you're terrified in these moments. And I remember I had pre-researched a facility in Mexico that I had heard really wonderful things about for different cancers. And I knew I needed to keep it in my back pocket because I did believe in the East meets West approach, but I knew there was going to be a moment to throw in the East, and I didn't know when that was going to be. And so I snuck her off, and we really optimized her immune system. There was a moment where I had this kind of message come through that said, maybe it's not the tumor growing back, maybe it's the buildup of the chemo in the system. And the side effects of growth of tumor and the symptoms of regrowth of tumor and the side effects of chemo actually really mirror each other. And that's what gave me the idea. So I took her to Mexico. There's a really great facility there called Baja Medgabe. And we detoxed her off the chemo. We supported her immune system with vitamin C drips and turmerics and all of these things that were curcumins that would help her, and cleaned out the diet. We did add some THC and CBD into the mix. And from that moment on, her tumor shrunk and shrunk and shrunk and shrunk. And so my biggest thing that I try to teach people, because I've been an unofficial brain tumor coach, I feel like on the side for so many people who reach out to me, is that East meets West is best. We really worked on having a no sugar diet. I had to amend at times because I was so afraid to give her sugar. And I realized that you need glucose to the brain, so we added fruit in. High dose vitamin C drips have been really helpful. I think the THC and the CBD has been helpful as well. Optune is a game changer. I cannot say enough about the Optune. The second she takes it off, we have a problem. So I feel like a great supplement regime, and you know, the folks in Mexico have been really helpful with that, and I've learned about Benagine and different supplements. Now listen, all of this isn't 100% proven to work, but when you have something like this, you have to try everything. And I tried to do it in waves so that I didn't have so many things thrown at her that I didn't know what was kind of helping. And so I have a show called Better Together with Maria Menounos that is available pretty much everywhere. If you go to my Instagram at Maria Menounos, you can click the link tree and find me. But I've done many episodes that have detailed exactly what we've done if you want to know more. And within the Patreon, we're going to start doing some workshops because I help so many people individually. It's so much easier to get everybody together and share everything that's been working. But the radiologist actually told me, he said, I firmly believe that the success that your mom has had has been because you guys have optimized her immune system so efficiently. And so, you know, it takes a village. We've had the most incredible doctors. Oh my gosh, and the healers. I've had energy healers, and I know a lot of people aren't familiar with that work yet, but it's what acupuncture was probably 30 years ago when it was starting to catch on. My mom was just before last Thanksgiving, couldn't even walk. And we barely got her on the table. And John Amaral, this incredible energy healer, worked on her. And by the time he was done, she was dancing. And she was able to get on a 20-hour travel trip and then get off the plane and go to the church dance and dance. And so I can't say enough about these alternative modalities. They really work, and it's been a game changer for my mom, and I know it's the reason she's still here and doing well.
So you took on the role as a caregiver and really were her biggest champion.
Mm-hmm.
It's so extremely important when you're navigating this disease to have someone like you as the quarterback of the team. Based on your experience, what can you share with our audience to help them be successful in that role?
It's challenging. I mean, a lot of people get sick taking care of the sick, so you have to be really, really careful with yourself. And in my case, I mean, I got a brain tumor myself. So it wasn't because of caretaking, obviously. But I think that what your job is, what's most important as the caregiver is to never give up, is to continuously be seeking knowledge and alternative ways. And the biggest thing I tell people is, you know, the flaws in the medical system is amazing. I mean, they perform so many miracles every day, but they only have so much time with you. I have the top breast cancer surgeon in the world on my show, Dr. Christy Funk, and she said, Maria, it is heartbreaking. We have 15 minutes with a patient, and that's with us filling out the paperwork and doing the exams. They can't possibly do everything that you would really need. And so there are so many patients that I help who say, you know, they set me off. They're like, okay, we're having surgery this day. And then they send you off and you're like, wait, what else? What else can I do? And they unfortunately don't really have the time, and they don't have, you know, the nutrition-based information. You know, they get a limited amount of that in school. So it's up to you to do that homework, and it's up to you to try things, even if they're not 100% proven. If you've seen enough results for yourself and heard enough good things, I mean, there are certain things that are nebulous. I mean, vitamin C, you're not going to get hurt with vitamin C. But individual care is so important, and you have to treat each patient individually. So I look at my mom, I filter all of the opinions, and then I look at my mom and I know her. I know what's going to work for her and I know what's not. And when I don't know and I'm terrified, I ask for guidance from above. And if I'm still enough and I've trained myself to listen to the messages, and I promise you it works, they come. And you just have to trust that what you heard is true and move and do it. But the individual care is the biggest part of this, is really watching where their symptoms are, how can you offset things, and yeah.
Thank you for sharing that.
Anything else? I'm like, did I miss anything else? I have all my notes because I go through this with so many people every day, but you know, you can listen to the show, and I share so much more. I know we have a limited time here, so.
Thank you. Thank you for sharing that. At the time of caring for your mother, you started experiencing symptoms of your own. Mm-hmm. Was there something inside of you that thought maybe you had a brain tumor?
Not initially. I was a type A workaholic who didn't know what I felt because I didn't have time to feel anything. And so I was having pains, I was having headaches, I was slurring my speech on the set of E! News. And I actually would joke, oh, it's my stupid brain tumor. Having no idea that I had a brain tumor, cracking jokes. And so it took me, I was having a lot of ear pain one day, and then the next day, and then the next day, and I said, wow, I forget how old I was then. I was 39, and I'm like, I have an ear infection? That is so strange. So I went to the doctor, and it was the first time I was seeing this doctor. And I said, I think I have an ear infection. So he checked my ear and he goes, nope, my dear, you don't have an ear infection. And I was like, okay. I said, well, I'm having all these problems. I'm having headaches, I'm slurring my speech. And as I went through the checklist, I go, oh. And he goes, what? I go, I know you're gonna think I'm crazy, but I think I have a brain tumor like my mom. And he said, I don't think you're crazy, and I don't like the symptoms you're rattling off, so let's get an MRI to rule it out. And so lo and behold, as I checked my mom into that facility in Mexico, I got a call from him, and he's like, I don't know how to tell you this. I said, I know what you're gonna tell me. I could tell on the radiologist's face when I walked out of that room that you guys saw something I knew. And so it was very surreal, very surreal.
How did you respond to that news? What did you do next?
I kind of chuckled. I laugh at serious things a lot. So I was like, this can't be happening. And then I texted my best friend in the whole world and I said, I have a brain tumor, but don't tell anybody because I haven't told my husband yet. I'll call you soon. And she still hates me to this day. But I just went out into the parking lot and I told him, because I couldn't tell my parents. Here we think my mom's tumor might be growing. I can't now pile on and say, oh yeah, guess what? I have one too. And I just kind of sat outside and was watching the sunset and I was like, this is crazy. And all I could think about was, no one's ever going to hire me again. I'm never going to get to work again. I'm going to be a liability. And so I knew I had to keep it a secret and I had to go on about my business. And it wasn't until about a week before surgery that I was highly advised by people that I needed to, like my doctor and my husband, like, you need to start telling a few people, you can't do this alone. And so, yeah, it was a wild thing, but I'll tell you, I knew I had a choice on how to go through this journey and I chose to go through it with humor. And the only time I shed tears was when I actually would tell a few friends, because I almost oddly felt weird to have to call them and say this really crazy thing to them. But I cracked jokes through the whole thing. I had a, name for the tumor. I called her Debbie. I'm like, friggin' Debbie hurts today. And I just had this name for her. And I played my Rocky theme music. Everything, if you know me, like, we love sports in our house and everything is either sports related, our mentality, our quotes, or Rocky. And so I had my Rocky theme music playing as I got wheeled into surgery on my birthday, by the way, on my 39th birthday. And I looked at it as a rebirth. When I said earlier that I didn't feel things, it was because I was going a million miles a minute, being everything to everyone and nothing to myself. And it's a shame that all of us will look at our bodies, and when our cars make noises, we take it to the mechanic. When our bodies make noises, we're like, shh, I'm busy. I don't have time for you. And so it really taught me an incredible lesson that I really had to pay attention. I had to live a more still life. I had to infuse a little more stillness. And I needed to focus on my health as well. And so that's been the challenge between two tumors in the house. I'm the caregiver, and then I have to deal with being cared for. So that was a challenging little period. And then, the continuous gift of being a caregiver, because that's what it is at this point.
Can you talk a little bit about that time? So you are navigating post-surgery, your recovery, you're a caregiver for your mother, you're still balancing your career. Can you just talk a little bit about how you balanced all of that, taking time for yourself as well as caregiving?
Well, after surgery, I really, focused on my recovery. My husband sent my parents on a cross-country trip. It was a dream of theirs because my dad was just devastated. He was looking at the two women in his life just down and out. My mom and I are sitting on a couch together, just black-eyed, and and so I said, honey, I'm not going to be able to recover with him being so upset. He would break into the room bawling his brains out. And I said, send them on a trip. And so he sent them on a cross-country trip, and I had my time to recover. And anytime I got anxious about recovery, because when they say it takes 4 to 6 weeks to recover, that's kind of funny. It takes like a year to recover. But I think I had really good friends. Kate Walsh, who came out with her brain tumor experience soon after mine, came over to the house and said, do not rush your recovery. And she told me that. She's like, it takes a year. And I was like, oh, okay, yeah. Okay, I can forgive myself a little bit and be more patient with myself. And the irony was when I saw Dr. Black, I said, so surely, you know, my tumor is going to be easier than my mom's, because at that point he looked at it and he said, it looks like a meningioma, but we won't know until we get in there and we biopsy. I said, well, surely mine's going to be a lot easier, right? And he goes, nope. And I'm like, what? And he's like, yeah, yours is in a really dangerous spot. And I was like, this is insane. It just kept getting crazier and crazier. So my surgery was almost 8 hours as opposed to my mom's, which was 4. And she handled it so much better than I did, because mine affected my balance nerve, and you know, it was really hard to walk for a while, and that was challenging. But all in all, we are doing great, and I'm so grateful for our team at Cedars, Dr. Black and Dr. Rudnick, and all of the nurses. Oh my God, the nurses were angels from heaven. And then our team at Dana-Farber that pinch hits when my parents were on the East Coast, and led by Dr. Reardon. So we're really, really lucky, and so many doctors and healers, like I said, in between.
Having both been diagnosed, you and your mother, how did you learn to cope with the new reality? Are there any tips that you can share with the community on how to help navigate the emotional impact of the disease?
Yeah, I mean, that's an ongoing battle, right? Because you go through so many different stages. You know, a really good support system, you can't say enough about it. And sometimes it's not who you think it is or who you think it's going to be. So don't be surprised when it's not them. I think that, you know, as a caregiver and as the primary caregiver, you need to find ways to escape and get a break and recharge your battery. I think that talking to people, whether it's a therapist or some version of a therapist, is always wonderful, because you have someone completely outside of the scenario to help make you feel less guilty, because generally you're going to have some feeling of guilt that you're not doing enough, or you didn't do it right, or you screwed up a pill, or you this or you that. We focus on my show every single day on things like this, on helping people with techniques to handle the various anxieties and depressions and stuff. So even like a technique like havening is really helpful. It activates both sides of the brain. So you can either do this and talk yourself through a very scared moment or an anxiety moment, or you can do this, and it's called havening. We did a whole episode with Dr. Daniel Amen last week on this, on Better Together. And what it does is it activates both sides of your brain and shuts down the fear and anxiety part. And so that's a really great tip and tool. And, you know, just realizing that you can't do it alone. You need to ask for help. And I know that's really hard for everybody. I don't know why we've all conditioned ourselves to think that we're Superwoman and Superman, but we're not. We don't have capes on our backs, guys. So one of the things that I really advise people is to have everyone have a different role. So, you know, divvy up the duties. You know, the pills are really a challenge, is keeping up with those. I've finally found companies that will organize them for you. And I know CVS just bought a company that will do that too. I don't know if they've rolled it out yet, but we found a pharmacy here in Connecticut that organizes all the pills and puts them in little packets. That saves so much stress and so much time. And, you know, who's going to be, you know, the person taking appointments with the patient, right? I have notebooks from every appointment. I write everything they say down so that I can go back and refer. I shoot video so that I can remember, because once you leave that office, you think you're going to remember, and then you leave, and then you forgot where you parked your car, and then your patient needs help getting in the car, and then they're hungry, or then they're sick, or something's happening. A phone call comes in, and then all of a sudden, wait, what did he say? Or what did she say? I don't remember. Keep a diary for every appointment. And then also every symptom. You have to pay attention to the symptoms. You have to keep asking, how are you feeling today? What about your leg? What about your eye? What about this? What about that? And make sure you're always investigating. You have to be your own investigator to see if the tumor is growing, it's going to push on different things. That's going to be your first indication that something's off. Are they doing something different? Is something hurting them? Is something not feeling right? That's where the reporter in me kind of comes in handy. So yeah, those are some of my tips.
Those are very, very helpful tips. Thank you for sharing that with the community. What are you doing differently since your diagnosis?
Since my diagnosis, like I said, I really committed to focusing on my health and my wellness. And that's why I went on the journey to start my show, Better Together with Maria Menounos, because I want to continue learning and growing and getting better in all areas of life. And I get to do that every day, and I get to do it with everybody. No, we don't know everything. And when you know better, you get better. And so every day I'm bringing in the top experts from all over the world to help us get better. We live in really challenging times, as you may have noticed, 2020 in particular lately. But we live in challenging times, and health is, it's so important, and yet it's so scary when you lose it. And having people that know how to navigate these health crises. No one tells you how to handle crisis. There's no handbook on how to do this. So we need to be reaching for people who have succeeded in it and can show us the way, like, you know, guide us through it. And that's what I do. I'm on an never-ending journey, basically, to find people to make every one of us better. And that's what I've committed to since the tumor, and trying to live as stress-free as I can. I'm not always achieving it, but that is my goal always.
You often mention that you do practice mindfulness and being still. Can you describe to us what it means for you to be still?
Yeah, so, you know, meditating is a way to do that. And I do it as often as I can. I can't say that I'm always perfect about it every day, but you know, I'm here on the East Coast, and I'll go out to the yard and just sit and meditate. And there's a really cool app that I love called The Breathing Room. And there's an app, a meditation in there called the Soul Sync. That's really cool. There's so many meditations that I love, but anything that can get your body and your nervous system to just calm down and get to a place where, you know, you can end it and say, you know, today is going to be a great day. And every time I do that, it is a great day. And going for walks, motion equals emotion. Getting your movement in is really important. And I always get downloads there too. And then I end my night with my gratitude list and my prayers. So I pray every night, and I thank God for every amazing moment. And what's amazing is you can go to bed after a really tough day, and most of the time you're going to remember the worst things. But when you practice this, you're like, oh my God, something amazing happened and I totally forgot. But when you start to rattle off all the things you were grateful for, down to the little hummingbird that showed up and you know, was right in front of your face, or you know, the person who called to check on you and make sure you were doing all right, whatever it was, you rattle off every single one and you realize today was pretty great. That was awesome. And you're grateful for it. And so all of these practices help get you in a good state and keep you in a good state. And that's important.
How are you doing now? Are you still experiencing symptoms?
Yeah, I do. But I deal with it. I recently was researching and found that some nice heat pads are helpful for any kind of trigeminal pains. So I'm always looking. And in fact, one of my listeners or viewers on my show said that she had found ways to shrink her meningioma. And I was like, excuse me, I need to know. So I got email connected with her just today, actually. And I will be finding out what she's been doing to be able to do that. But yeah, I think, you know, it's definitely something that I'm really passionate about, is helping people get better. And I'm doing all of this myself every day too.
I'd love to talk a little bit about your show, Better Together, which is dedicated to learning how to better ourselves as individuals and as a community. Can you talk to our community about how this may be beneficial to them as patients and caregivers?
Oh my gosh, absolutely. It is, it's must-see TV for all of us, I think, because it's born from necessity. It's not just for entertainment. I mean, we'll have a little bit of fun at the top of the show, but really it's my mission to bring the best of the best in all areas of life to help us get better. And especially in health and wellness and spirituality. You know, there are so many things like the havening technique, and I've been a reporter for 2 decades interviewing the best of the best. And so I've amassed a great Rolodex, and then it keeps expanding as my focus is so on it now. But I didn't know about havening. Did you?
I didn't know. No.
A simple thing to do that is scientifically proven to help you. So those are the things that we're finding every single day from people. Those tips and tricks to get better in your health, in your wellness, in your emotional state, in your spiritual world, everything, and opening people's eyes to it. You know, for me, every day it's exciting to find people who have never exposed themselves to these kinds of modalities or these thoughts, and expanding your brain is so important, right? If you keep a certain peer group, you're only going to be exposed to what they're exposed to. And so if you find, you know, a podcast or a show like mine where you can broaden your knowledge base and your mind and see what else is out there. I mean, that's why I think, the internet is so amazing, because we have it all at our fingertips. And I'm really passionate about helping people, always have been. And that's what I do every single day. And I'm helping myself at the same time.
And people can find your podcast, your show, YouTube, through your Instagram, where else?
Yeah, so we're on YouTube, we're on Apple Podcasts, Spotify, we're live on Facebook every day at 11 a.m. Pacific. But if you go to my Instagram at Maria Menounos, that's me, noun, OS. Thank you, Tiffany, from the 6th grade, for teaching me that. I have a link tree there, so you can just click inside and follow and subscribe. It is absolutely life-changing stuff every single day. Being a journalist for so many years, I know how important takeaway is, and teaching people and helping people is something that I really love. So this is not supposed to be an ad for the show. It really is to help everybody who's listening find tools and techniques to help themselves or somebody that they love.
Yes, I've definitely gone out and listened to some of the shows, and you do cover, such important topics, and with so many different people. And so I highly suggest that people do go out and take a look at it. What advice would you give to those who are newly diagnosed, just starting out on this path?
Newly diagnosed. Okay, don't read life expectancy statistics. I think that was the best thing that I did in the early days. I didn't want to know, because I wasn't looking at that as my goalpost. It's really important to know that there are so many ways to attack this. So you have to really try to have a positive mindset. And if you have your eye on that kind of life expectancy statistic, it's going to be really challenging. So it's staying positive. It's knowing that there are people who are living long lives, and fairly normal long lives. A friend of mine is a GBM survivor of 6 years. People magazine just did an article on him, and he's living a completely normal life. He had a full resection. He was my goalpost, because he was already 2 years in when my mom got diagnosed. And I'm like, please God, if we could just make it, that would be amazing. And so I think the mindset is really important. I think who you're going to surround yourself with is really important. I think that diet is extremely important. People will tell you, that you can eat whatever you want. I don't believe that. I believe that food is thy medicine, and I believe that sugar is the worst thing you could do. So I think depriving tumors of sugar is really important. And I think that getting multiple opinions before you have an operation, people get more opinions on a renovation on their home than they do for their brain. Do you know I've coached, I mean, maybe 50 plus people through brain surgery at this point, and not one of them got a second opinion until I forced them. And so multiple opinions, supplements, getting your body and your immune system strong. I know during radiation you can't, and I didn't do it during radiation either for my mom, but in those windows where you can, and when radiation is done, you have to supplement your body. I think that different modalities, like I said, energy healing are really important. I think the vitamin C drips are really important. I give those to my mom monthly. I think that seeking places like a Baja Medgate in Mexico are really important, because they've done so much work already that you can benefit from, and they cater the treatments directly to you individually. And so I think that's really, I'm trying to think of everything. I go down my list with a new patient when I'm coaching them. Diet, we do Mexico, marijuana. You really want to look into that. If you see Ricky Lake's documentary, Weed the People, it's a really great documentary, Weed the People. You get to see how effective that can be. And Heal, the documentary Heal is another one that I always suggest. I have viewing and then I have reading. Those are some of my viewing suggestions. Heal is an incredible documentary where you'll see incredible healing modalities like energy work and Reiki and all kinds of things, and open your mind to some of these other things. And I've used all of them on my mom, and every one of those practitioners has been at my home, and I've sent them to so many others. And the reading, I always read, tell people to read Radical Remission. I think that was a really incredible book. And then Dying to Be Me by Anita Moorjani is another one that is really incredible, where she had cancer all over her body. They were told to read her last rites, and she had a complete radical remission. It shows you that there's hope, but it also shows you why she got there. You know, a lot of us are either repressing who we really are, living life for everybody else, never listening to our own bodies and our own desires. And so when you start to think about why you end up with a certain ailment, you have to look at the root of all of it and the choices and the things that have led to it. You know, I know my mom lived for everybody else, did nothing for herself, and worked in really toxic environments and with toxic people. And I know that that takes a toll. I 100% know it takes its toll. So, you know, if you're newly diagnosed, you're going to want to look around and make sure that you are only with the brightest and the best. You can't handle any negativity right now. It should all be about you and how we're going to get you better. And looking for hopeful stories. Like when I did my Dr. Oz episode, if you guys Google Dr. Oz and me, you'll see that the one prerequisite I had for going on the show was that they could show survivor stories. At the time, Megan McCain's dad was dealing with glioblastoma, and Megan and I were talking a lot, and I was trying to instill hope in her. And he filled half of his audience with survivors that were up to 10 years. And it was the most beautiful moment. Of course, I lost it. But there are people, and you can be one of those people. You just have to believe it. And, you know, I do believe Tony Robbins, actually, when I got diagnosed, he was like, honey, he's like, whatever you believe will be. And those are really powerful words. And I know that it's a challenging thing, because we also can't control what God does in the end, but we can control how we react and how we respond. and how we choose to go through this. And so, like I said, I chose to go through my journey with humor. That's not for everybody, but I hope that you'll choose a path that is more positive and with the right people around you, so that you can have a better journey, whatever that journey is.
Thank you. Parting thoughts. What motivates you to keep going every day?
It's just in life in general.
Mm-hmm. Yep.
That's a really interesting question. What motivates me to keep going every day? I mean, I guess I would have to say I love learning, and so I'm addicted to that kind of self-help, wellness, health, learning journey. I love helping people, so every day I get to do that. I feel good, and yeah, and I'm Greek. We love life. So,
well, Maria,
I'll say one last thing. One of the things that really helped me through this journey that I want to share with you guys before we finish is an incredible tool. It is a tool, okay? And it got me through my tough moments with my mom. It gets me through my tough moments with, myself. And it's life is happening for you, not to you. So there's a reason for everything. And if you start to uncover the whys and start making adjustments and looking through it like that, it's really a helpful tool. And it's challenging, trust me. There have been so many terrifying moments with my mom, but there's always a reason, and I hope that will help you.
Thank you very much for that. Thank you. And thank you so much for sharing your story with the ABTA community today. We're really honored to have you as part of our program and appreciate your willingness to share your personal experience as a caregiver and patient. I truly thank you for your vulnerability in opening up today and sharing some of the innermost challenges that you've had to go through. It's evident that you and your mother are not allowing a diagnosis of a brain tumor to deter you from living your fullest life. And your story truly inspires and encourages and will continue to bring healing to other people's lives as well. So thank you again for being here today.
Thank you. Good luck, everybody.
Thank you. It is now my honor and privilege to introduce you to ABTA co-founder and honorary board member, Susan Kramer.
Oh, it's an honor to be here today with all of you as co-founder of the American Brain Tumor Association. It is astounding to witness the advances that have been made in research, treatment, and care, and to see how ABTA has contributed to those advances. When we started this organization 47 years ago in search of a cure for my daughter Stephanie, we could not have imagined what it would become today. I am so proud that a small family foundation out of our home could become a resource and a strong advocate for people who were going through the same thing that we went through. I am so proud that this organization now serves people all over the country and the world. We hope today's programming offered hope and encouragement, but mainly to show you, you are not alone. The ABTA is here to serve you through information, support, services, and research. Thank you.
Thank you so much, Susan. And thank you so much, Maria Menounos, for sharing with us your personal experience, walking through caring for your mother, and also you going through your own tumor diagnosis. Both of your determination, Maria and Susan, truly will inspire each of the individuals that have been on here today. I just want to say thank you so much for all of you who have joined with us today. This now concludes day one of the 2020 ABTA Virtual National Conference.